to chair the session.
Good afternoon, ladies and gentlemen. Welcome to this special symposium on sudden cardiac death. Let me introduce my co-chairs. Well, they need no introduction, Dr. Asanga Dunivilan, Dr. Chanaka, both consultant cardiac electrophysiologists. And this is a very interesting session where we are going to discuss various causes and assessing and prevention of sudden cardiac death, which is a very tragic and rather emotional situation when it occurs in hopefully a healthy person dying suddenly, which can be prevented. Okay, Dr. Asanga Dunivilan will introduce his colleague and friend, Dr. Naya now.
Yeah. The initial lecture will be done by Professor Mohan Naya, who's a well-known electrophysiologist in India and in Sri Lanka as well, and he had made many visits to this country and helped to develop electrophysiology from the initiation itself. He had worked in many hospitals in India, moving from one to the other. At the moment he's working in a missionary hospital, as well as he involved in developing a medical school attached to the unit. Prof. Mohan has a special interest in wide variety of electrophysiology topics, and his main interest is in sudden cardiac death. Dear Mohan, may I invite you to deliver the initial lecture, which is the diagnostic, which is the assessing the risk of arrhythmia in coronary artery disease.
Mr. Chairpersons, ladies and gentlemen, a very good afternoon to you. As Asanga said, I used to come very frequently to Sri Lanka until I became almost a part of furniture here, and then they stopped calling me. So this is after a bit of a gap. It's been 4 years since I came here, but each time I come here, it's gratifying to see old friends, gratifying to see how Sri Lankan cardiology is moving, and particularly the field of electrophysiology. I'm extremely grateful to Asanga, Naumali. In fact, Naumali actually gave me an oration when she was president of the SHLI, and which today remains one of the most prized possessions in my office room. When you think of arrhythmias in coronary artery disease, how do I move this? Yeah, the one which you're most worried about is this broad QRS ventricular tachycardia and ventricular fibrillation. Precisely because not only these cause hemodynamic compromise, but as one of the chairpersons said, it's a leading cause of sudden cardiac arrest. And whatever else you do, you need to prevent sudden cardiac arrest in these patients with coronary artery disease. There was a time we couldn't do too much about preventing sudden cardiac death, but if you now upfront identify these patients, not only are there many drugs which have been proven in large studies to have an impact on sudden cardiac arrest in patients with coronary artery disease, we also have devices which can almost 100% guarantee that the patient will not die of a sudden cardiac arrest. It's also good to know that this form of therapy is now easily available in Sri Lanka and other parts of Asia. So we need to know which are the patients with coronary artery disease. There are patients and patients and patients of coronary artery disease. Which are the ones who are at particular high risk for sudden cardiac arrest, so that you look for them and do something specific or more intensive to prevent sudden cardiac arrest. Now to begin with, and one thing I like about speaking in meetings in Sri Lanka is that I understand that there are a lot of students and young physicians. So if you were to see a coronary artery disease patient, you know all those XYZ things that you need to do. But first and foremost, the patient who is at the most risk for sudden cardiac arrest is a patient who's had a myocardial infarction, a patient who has a scar, a patient who's had a heart attack has 4 to 6 times the chances of dying suddenly as compared to that of a general population. So you have already identified one patient post-myocardial infarction. Among patients with post-myocardial infarction, who is at risk for sudden cardiac death? Not all patients who have acute myocardial infarction or a remote myocardial infarction are at risk of sudden cardiac arrest. Who are the ones? After a lot of studies, after a lot of analysis, it's now very clear that the single most factor that determines sudden cardiac arrest risk in a patient with coronary artery disease is reduced ejection fraction. Less the ejection fraction, more likely that the patient will have sudden cardiac arrest, regardless of how remote he is from his index coronary artery or myocardial infarction. See here, there was a time when we were students, we were told that look at, after all, sudden cardiac arrest is a ventricular arrhythmia arrest. So look at ventricular arrhythmias. If you see the, I don't know whether this works. If you see these graphs on the right side, it doesn't matter what is the density of ventricular arrhythmias you have, as long as ejection fraction is maintained. The moment the ejection fraction comes down, then the ventricular arrhythmia density seems to have meaning. So clearly, far more than the ventricular arrhythmias that you detect either on a casual ECG or on a Holter is the ejection fraction which finally determines whether the patient is going to die suddenly or not. So far, so good. The same, see here, 0 to 30% ejection fraction versus more than 50% ejection fraction. I keep telling that if a person has an ejection fraction of more than 40%, he is more likely to die of an accident or a gunshot wound rather than have a sudden cardiac arrest. So this is what led to upfront putting of an ICD in patients with a low ejection fraction in most of Europe and in the United States. Is that all? The problem is that 2/3 of these patients who have a device purely on the basis of an ejection fraction being low do not use their device. And that's a lot of cost in terms of putting, say, 10 devices to save, or 100 devices to save less than 20 lives. So we need to look more than just ejection fraction. The second downside is that close to 1/3 of the patients who die suddenly, or even more, up to 50%, do not have a low ejection fraction. So on one side, ejection fraction is not a foolproof. On the other side, having a normal ejection fraction in coronary artery disease does not necessarily protect you from sudden cardiac arrest. So where do we go from here? Go back to the basics. Look at the patient profile. We all know the risk factors for coronary artery disease, but we now know among patients with coronary artery disease some risk factors that make you more prone for sudden cardiac arrest. If you have a family history of sudden cardiac arrest, that increases the chance that if you have an MI, you'll have a sudden cardiac arrest. If you have family history of sudden cardiac arrest and you are a male, then of course, it increases even more. If you have family history of sudden cardiac arrest, main gender, and you have currently a smoker, it increases even more. And most importantly, family history of sudden death, male gender, current smoker, and cardiac hypertrophy increases your chance, odds ratio, by almost 5 times. So among all the other risk factors for coronary artery disease, these are 4 risk factors. If you find in a patient, then you must be very careful to try and see what best you can do to prevent sudden cardiac arrest in these patients. What about treadmill test? I'm just talking of simple tests. Does that predict sudden cardiac arrest? By and large, ventricular arrhythmias seen during terminal tells you nothing about future events of a ventricular arrhythmia or a ventricular arrhythmia-related death. All it tells you is that there's a slightly bigger chance of you having more coronary artery disease. It does not tell you anything. What about the coronary angiogram itself? From single vessel, this is not working. If you see the number 1, between single vessel and double vessel disease, there's not too much of difference between sudden cardiac arrest. However, the moment you go to 3 vessel disease, if a patient has 3 vessel disease, regardless of other factors, there's a higher chance of sudden cardiac arrest. And this 3 vessel disease, of course, includes left main disease and also 2 vessel disease with proximal LAD disease. So each of the tests that you do in a routine workup of a patient with coronary artery disease immediately tells you his risk of sudden death and also his risk of a recurrent MI. There are several other things that have been studied. I'll just rush through them. The functional class of a patient, like in a whole lot of other diseases, heart failure, etc., tells you nothing really about the way the patient can die because it's so much dependent on so many other factors. So functional class does not add value to the risk already assessed by his LV ejection fraction. Now remember, it's an arrhythmic death. It's surprising that we're looking at things, it's an electrical event. And the best electrical tool that we have, to understand electrical happenings inside the heart is the electrocardiogram. So it's not surprising that multiple things on the electrocardiogram have been looked at. I will focus on things which can be easily done and are useful in terms of predicting sudden cardiac arrest. The resting heart rate, abnormal depolarization, etc., etc., etc. The QT measurement, unlike the congenital QT measurements, do not predict in a patient with coronary artery disease the risk of sudden cardiac arrest. What about left bundle branch block? We know that the wider the QRS, the worse is the patient in terms of recurrent events, the worse is the patient in terms of congestive heart failure, the worse is the patient in terms of deteriorating functional class. Does the QRS tell you about sudden cardiac arrest? Unfortunately, no. If you see here, patients with moderate or mild LV dysfunction were followed up. They all had a broad QRS, left bundle branch block, but the red line is a patient with a broad QRS. The blue line is a patient with a normal QRS. It did not tell you, as long as the ejection fraction was reasonably preserved, it did not tell you the risk of sudden cardiac arrest. However, if you look more closely, and this is again what I keep telling my fellows, if you look more closely, the moment you find notching in the QRS, in any disease, let me tell you, in any disease, notching in the QRS is a bad sign. Notching in the QRS means the myocardium is diseased and there is also irregular repolarization within the myocardium. There are fast and slow areas of conduction, and that's the worst thing. This is across the board. This is not only in coronary artery disease. You see an ECG, if it has too many notches, then you have to be worried. Honestly, I remember I got an ECG on my cell phone about a patient being admitted. Immediately I said, this patient is going to do bad. Young lady who had come with a broad QRS with notching. I said, this is bad. And before I said that, the patient had a VT-BFRS. So please remember that beyond looking at QRS morphology, beyond looking at QRS bit, and it's the same when I come to the next talk, notching of the QRS, whether this is left bundle branch block or right bundle branch block, is a bad sign and is a predictor for sudden cardiac arrest. See here, prior diagnosis of CAD is the same as fractionated QRS in the anterior leads. If you have both fractionated QRS and prior diagnosis of CAD, that predicts sudden cardiac arrest far more than any of the other factors put together. This has been going on for a very long time, the signal average ECG. But again, if you see studies, the sensitivity and specificity of late potentials is too low to be of any clinical value and cannot determine whether X or an A patient gets an ICD versus a B patient who should not be given an ICD, which is good because it's a tiresome thing to do. This is, again, just to complete the list, a microwave T-wave alternance. If you have a T-wave on the Holter or beat-to-beat variation in the T-wave amplitude, and if it is too much, I don't want to go into the numbers, if it's too much undulation, again, that means that there's a dispersion of depolarization, and that's a bad sign. That can be again seen on a simple 12-lead ECG. Of course, it can also be seen in a Holter or ambulatory monitoring. Again, this, when it was put to test in trials, there was no change between those who had these undulations versus those who did not. But I think it's good to look at these subtle changes in the ECG to see whether this patient could die suddenly or not. What seems to matter more is the T peak to T end interval. Looks very complicated, it's very simple. If the T is very broad, that means again dispersion, there is a lot of dispersion of depolarization. Depolarization is occurring very late, which means that the myocardium is electrically active in a bad sense with slow conduction. And if you see those, the cases are the red one. The longer the duration of the T wave, that is the T peak to T end interval, that's a broad, not too tall T wave, the more likely that the patient will have sudden cardiac arrest. So this is far more simple to see than late potential and microwave T-wave alternance. This can be seen on the 12-lead ECG. So there are several things. If you see on the top, if you just look at the ECG, that tells you, of course the echo also, that tells you a lot on whether an X patient is likely to have sudden cardiac arrest, which means that you are more intensive in terms of all those drugs which I listed that have been proven to prevent sudden cardiac arrest. And if the opportunity occurs, you need as a physician, as a good cardiologist, to recommend an ICD or at least keep the patient on close watch. What about EP testing? This is bread and butter for me, and this is bread and butter for Asanga. And it's an electrical issue. How about if you stimulate the heart and see if it is going into ventricular tachycardia or ventricular fibrillation? Unfortunately, or maybe fortunately, EP testing, that is induced ventricular tachycardia in the lab, this is being studied, of course, induced ventricular fibrillation is something else that's being studied, but induced ventricular tachycardia in the setting of a coronary artery disease does not predict future sudden cardiac arrest in these patients. Finally, imaging. We said in the beginning that the single most best predictor is an imaging modality, that is an echocardiogram. The next best is a careful look at the electrocardiogram, but these have their limitations. What we are doing now is to invest a lot on imaging by cardiac MRI. Cardiac MRI actually gives you an extent of scar, where the scars are, and the scattering of scars. And increasingly, I don't know how easily it is available here, you require to have a cardiac MRI machine, but far more importantly, you need to have a person who can read those MR images very well. It takes a lot of training. We are investing a lot on cardiac MR to detect and actually drive our treatment protocols. And this increasingly is all over the world being used to predict those patients, regardless of the disease, whether it's coronary artery disease, cardiomyopathies, everything, cardiac imaging is increasingly becoming the gold standard or a very important tool for us to predict arrhythmias in patients with coronary artery disease. In fact, our first paper on CMR in so-called normal heart VT is in the final stages of publication. We do have some data already on patients with coronary artery disease, and hopefully we should be publishing that soon. So in the end, before I finish off, my topic was prediction of arrhythmias. So one was all those arrhythmias which cause sudden cardiac arrest. The other arrhythmia that's often neglected, but perhaps is as dangerous or as devastating in a patient, especially with LV dysfunction, is atrial fibrillation. For atrial fibrillation, the predictors are if the age is more than 65, if the duration of coronary artery disease is more than 6 years, if there's heart failure, and if there has been previous acute MI. As I said again, previous MI is a scar, and the scar might involve the left ventricle and also sometimes the atrium. So if you have these factors, you must know that these patients are at more risk for atrial fibrillation, and onset of atrial fibrillation is actually almost as dangerous as non-sustained VT or VT that is hemodynamically stable, because this is an arrhythmia that pushes the patient terribly down on the New York functional class, pushes these patients into heart failure, and to me, it's the beginning of the end in patients who already have a depressed LV ejection fraction. Must also understand that in a lot of patients who have an ICD, and you look at the arrhythmia that triggers ventricular fibrillation and sudden death, very often it's an atrial fibrillation which triggers. So you must know which are the patients who are at high risk for atrial fibrillation. I don't have time for discussing other arrhythmias, but I think the symposium is on sudden cardiac arrest. I did cover most of it. So in the end, it's just simple tools. It's just that some people have the habit of talking of electrophysiological studies, microwave, T-wave alternance, late potential, etc., etc. Ejection fraction, a good look at the ECG, and if possible, imaging with MRI tells you very clearly which patient with coronary artery disease is going to have sudden cardiac arrest versus which patient is likely to remain stable. Thank you very much.
Thank you very much, Professor Mohan, for excellent presentation. We will give some time to ask questions after all three presentations. We'll next move to the next presentation, that is how extensively we should screen athletes. The presentation will be done by Dr. Leslie Cooper from Mayo Clinic. Dr. Cooper doesn't need any introduction. He has already given two presentations in the morning, so over to you, Dr. Leslie.
Well, thank you again very much, and welcome back, everyone. I hope lunch hasn't given you too much tryptophan. You're not falling asleep yet. But I'm delighted to take the next 20 minutes to share with you an area of significant controversy. There's really a difference of opinion, significant difference of opinion between the European guidelines and the US scientific statements when it comes to the use of electrocardiograms to screen athletes for pre-participation physicals. So we're going to go over some of the data supporting the current recommendations, and then hopefully leave you with thoughts about what is the best strategy in Sri Lanka and locally. And I, again, have no relevant financial disclosures. This is Elisa Rojas, and she passed away at age 5 in Denver of myocarditis. And the reason I show this is because her family, her father and her mother, became very active in the Myocarditis Foundation, a group that I had founded to help families and physicians with myocarditis. They became board members, and her story illustrates two things that are relevant to us today. Number one, sudden death in young people does not primarily occur in athletes. The vast majority of cardiovascular sudden death occurs in non-athletes. And the second is that you have causes, important causes of sudden death that are not screenable, where hypertrophic cardiomyopathy or long QT syndrome can be diagnosed often or by an EKG. You can't really screen for myocarditis until it occurs. And so I want to highlight those 2 points as we move forward. This is a slide from one of many studies by Barry Marin looking at the causes of death attributable to young individuals less than 25 years of age. From the US, you can see that by far, motor vehicle accidents, homicides, and suicides are sadly the major reasons for death in premature death in young individuals. All of cardiovascular disease together is about the same frequency as cancer. And then way at the bottom, you can see US athletes at 76, way below even leukemia and drowning. And so I want to frame our discussion because we're talking about a very tiny percentage of the actual number of premature deaths in young people. Here is another study that looks at a comparison of the general population with young competitive athletes. And you can see in blue, which is the point of this slide, that the majority of sudden death in the general population remains unexplained. And the reason for that is that many people do not have an autopsy. They may die at home. There may be no reason known. And even in young competitive athletes, and when I first started studying this field, I was really surprised to find out that a third in most of the published studies actually have never had an autopsy. Now, you would not necessarily need an autopsy to diagnose hypertrophic cardiomyopathy, but you would for a disease like myocarditis, which is only diagnosed by histologic examination of the heart. There is a study looking at the isolated study of one piece of the left and right ventricle compared to sections systematically taken every 5 millimeters, and the frequency of the diagnosis of myocarditis increased fivefold, 500%, fivefold between the isolated sampling method and the systematic sampling method. Again, pointing to the fact that you need to think about it and specifically look to make certain diagnoses of sudden death. When you focus then into that tiny group of people who die suddenly due to cardiovascular causes, the most common reason is hypertrophic cardiomyopathy, a disease that is frequently diagnosed by a surface EKG. The coronary artery anomalies are almost always number 2 on the list, and those would require stress imaging in an asymptomatic patient, usually to make that diagnosis. Then premature coronary disease, particularly after age 30 or 35, isolated or inherited cardiomyopathies, and finally myocarditis. This frequency varies greatly by world region. And for example, in the Veneto region of northern Italy, there's a high rate of arrhythmogenic right ventricular dysplasia. That is not the case in Minnesota, where I practiced for a long time. This slide looks at the reported sudden cardiac death incidence in general American adolescents, and who are young athletes. And you can see that between ages 12 and 19, the incidence was about 6 per 100,000, but it was very different in male versus female. In male athletes, it's much higher than female. And in black athletes in the United States, it's, again, the relative risk is much, much higher overall and within the NCAA, which is ours. And so if you look at these in aggregate, the annual risk of sudden death in the United States varies between about 1 in 80,000 and 1 in 120,000, a fairly low number. But keep this in mind as we consider screening and the best way to screen to prevent sudden cardiac death. If you these data continue, the heterogeneity between races in a comparison of white athletes from North America in blue and non-white athletes in green. And you can see on the left, both for hypertrophic cardiomyopathy and for coronary anomalies, there's a much higher rate. The 2 most common disorders in non-white athletes in the United States. Again, the reasons for that are probably complex. There are three groups of disorders which you should consider when thinking of screening. The first and most amenable to screening would be the structural cardiac anomalies. These include hypertrophic cardiomyopathy as the most important. Arrhythmogenic right ventricular cardiomyopathy that I mentioned varies significantly between world regions. Congenital coronary anomalies, Marfan's, which is usually diagnosed by physical exam, and again, mitral valve prolapse or aortic stenosis, which you would pick up by auscultation. The electrical channelopathies and anomalous bypass tracts like Wolff-Parkinson-White may or may not be present on a surface EKG. Long QT would, but it's quite uncommon. Brugada, we're going to have a lecture about in 15 minutes. And then the other, the catecholaminergic and outflow tract VTs. The acquired disorders in the bottom right, myocarditis, trauma, toxic use of drugs, obviously you can't screen for and are important contributors. Here's an echocardiographic image of a markedly thick septum, which is typical for outflow tract basal septal hypertrophic cardiomyopathy. It is autosomal dominant, and so a good family history is really important in pre-participation screening. Sudden death is particularly common in basketball, start-stop sports because of the mechanism of arrhythmia, and it's common enough that one should consider screening beyond just a simple physical and history examination. With an EKG, you can pick up changes of hypertrophy illustrated by the red arrow in the middle, and more diffuse T-wave inversions, which can be present in other disorders as well. There's an overlap between the normal physiologic adaptation to exercise, or the athlete's heart, and hypertrophic cardiomyopathy. In the middle range of septal thickness, between, say, 13 to 14 millimeters, it's sometimes hard to tell whether this is an adaptation to competitive sports or whether this is actually a genetic abnormality. In the absence of a family history, it can be hard. This study, now a few years old, looked at the ratio of the thickness of the septum to the ventricular cavity diameter. And you can see in the hypertrophic group, they had relatively small ventricles. In the athletes, the size of the left ventricular end diastolic dimension, measured in the parasternal long axis view, was consistently larger. And you can see it illustrated here on these still frame echocardiographic images. At the top, a typical athlete heart with a 13 millimeter septum, but a 58 millimeter end diastolic dimension, and a hypertrophic patient on the bottom, again with a 13 millimeter septum, but only a 48 millimeter end diastolic dimension. The authors recommend in that intermediate range, first looking at the cavity size and the cavity to wall thickness, septal thickness ratio, followed by the size of the left atrium. The left atrium should be larger in hypertrophic cardiomyopathy. They would be symptomatic perhaps from the outflow tract obstruction in hypertrophic cardiomyopathy, the diffuse T waves, the family history. All of this could be very helpful once you have an echo. Arrhythmogenic right ventricular cardiomyopathy, again, if it's frequent in the Sri Lankan population, it may be very reasonable to screen with an EKG, which is currently the European Society of Cardiology recommendation, illustrated here. But this study, again by Barry Marin, a few years old now, looked at a comparison of the Minnesota rate of sudden death in athletes, cardiovascular sudden death, compared to those in the Veneto region of northern Italy. And you can see in Veneto in blue the significant decrease in the rate of sudden death once screening with an EKG was instituted. But that decrease only began to approach the low rate of sudden death that was already present in Minnesota, a region of the world that does not have much arrhythmogenic right ventricular dysplasia. This suggests that the optimal screening mechanism, with or without EKGs, really depends on the population you're screening. So when you have first the athlete's heart we talked about, which is usually asymptomatic, people who can run marathons without symptom limitation, you may have LV dilatation, which is not usually the case in hypertrophic and normal RV function. Hypertrophic cardiomyopathy, where you may have symptoms, you may have a family history, you may have pathologic Q waves, and you often will have a relatively small cavity size. And finally, arrhythmogenic right ventricular cardiomyopathy, You may have a family history, you may have epsilon waves, but often you're going to have impaired right ventricular function as well. In between, there are always the intermediate phenotypes. We talked about the intermediate phenotype between hypertrophic cardiomyopathy and athlete's heart. There's also an intermediate between athlete's heart and ARVC, which consists of borderline right ventricular dilatation, perhaps an incomplete right bundle, perhaps some extrasystoles. Here's an example of long QT syndrome. You can see, I think pretty obviously, the prolonged QT interval. There's obviously multiple subtypes. I show this only as an example of one uncommon but important cause of sudden death. The last part of my talk, I'll mention the things that you can't screen for. Myocarditis, we heard about earlier. Often, we don't think about it until somebody you know, a famous sports figure or a music star, gets sick. In this case, it was Rachel Hunter, Rod Stewart's wife, who is also a famous model, got myocarditis. She went public with her story and actually was active helping the Myocarditis Foundation as well. We saw this before. Sudden death is due to cardiovascular disease and myocarditis is relatively uncommon, but is mostly in males, largely due to testosterone-driven IL-17 mediated changes in desmosomal proteins, and 40% have no antecedent symptoms. So what should we do? This is the 12-element American Heart Association recommendations for pre-participation cardiovascular screening. And everybody in the US, our kids who went through high school and participated in sports, had a really good focused cardiovascular history and physical, looking for these 12 things: exertional chest pain, syncope, unexplained dyspnea or fatigue, the murmur we talked about, or hypertension, which could be a sign of fibromuscular dysplasia, premature death in the family, disability from heart disease or unknown premature death, and a physical exam with a murmur, excluding coart, doing Valsalva to try and bring out an outflow tract murmur, and then the signs of Marfan's. Currently, the American College of Cardiology does not recommend the universal use of 12-lead EKGs in young people in this age range, 12 to 25, because the number of false positives was felt to be far, far greater than the number of true positives. This study, which was published in the New England Journal of Medicine last November, directly addressed this. It's a series of patients from Canada, all of whom had sudden cardiac arrest, and some of whom were engaged in competitive sports. Just over 3 million people from Ontario, Canada, were included in the study in 2011. They had 18 million person years of follow-up through 2014, and 11%, 352,000, were athletes. There were 3,800 cardiac arrests, and this is the way it broke down. Of those thousands of arrests, only 74 actually occurred during sports. And at age less than 35, there were both structural and primary arrhythmias. There were only 2 cases of hypertrophic cardiomyopathy and 1 of ARVC, which means that 146,000 people would need to be screened by an EKG to prevent one sudden death potentially, and 700 would have been disqualified from sports based upon the estimated EKG abnormalities. So in conclusion, sudden cardiac death in athletes is rare, thankfully incredibly rare, and absolutely tragic when it happens. In most, if not all series, males are more affected than females, and there's a significant ethnic difference which may lead to a differential risks and alternate and multiple proper screening algorithms. Hypertrophic cardiomyopathy is always number 1, coronary anomalies almost always number 2, and then after number 2, it really depends on where you live. In northern Italy, it's ARVC. Following the AHC-ACF 12-element guideline for screening, there's a 14-element screening in Europe, which is very similar. And then the role of routine EKG is today still controversial. In my own practice, I don't see many young athletes, but I would not normally go straight to an EKG unless there was something on the initial screen that led me to that. And again, if you do pick up a history of myocarditis, abstain from competitive sports for 3 months, 6 months in the Caforio recommendation, unsure about MRIs. And with that, I thank you very much for your attention.
Thank you, Dr. Leslie Cooper, for that excellent talk. As you mentioned at the beginning of your talk, the Sri Lankan rates for sudden cardiac death and pre-participatory screening. We will talk about that at the end of the talk. So the next will be, again, let me re-invite Professor Mohan Naik to give his talk on approaches to Brugada-like ECG.
Yeah, in the best of scenes is a very difficult topic, how to approach a Brugada-like ECG. I think most experts still don't know what to do. I'll just take you through how the science of Brugada ECG is evolved. In 1992, the Brugada brothers, Pedro, who works in Belgium and Brussels, and Joseph, who works in Barcelona, came out with this new entity where there was right bundle branch block, persistent ST elevation, and sudden cardiac arrest, which was a distinct clinical and electrocardiographic syndrome in young patients who had died suddenly. Till then, we knew more about long QT syndrome and its variants. The ECG they described was this, a right bundle branch block pattern in the right precordial leads with J-point elevation and a coved ST segment with a terminal T-wave inversion. Fast forward to just 2 weeks back, and this is from the New England Journal of Medicine, June 7th. It says it's one of those clinical problem-solving reports. It says a shocking turn of events. What was shocking? A 38-year-old woman presents to the physician's office with shortness of breath, non-productive cough, palpitations, intermittent non-exertional chest tightness. She has no dizziness, lightheadedness, syncope, fever, chills, or sweats. She has this ECG. Again, if you see the right precordial lead, there's a J-point elevation with a coving ST segment, T-wave inversion. How many of you would considering Pedro Brugada's article, would give this child or a lady an ICD? How many of you? Raise the ones who would, raise the ones who don't know. You don't know. So what happened actually was, this is from Harvard Medical School. This lady was given an ICD. And what happened, I'm just cutting short the whole story. This case, incidental finding of an abnormal ECG in the absence of confirmed ventricular arrhythmias and syncope led to implantation of a cardioverter defibrillator. So they obviously are not fools. For primary prevention, the fear that this ECG, like long QT, could lead to sudden cardiac arrest. And the procedure was complicated by lead dislodgement, lead fracture, and superior vena cava syndrome. All that you can have with the device. So putting in a device is not a joke. And this patient actually finally had to have the device removed. So you have on one end an ECG that can be a predictor of sudden cardiac arrest. On the other hand, you can have the same ECG in some patients where it means nothing. So how do you decide? The truth actually lies somewhere in between. Let's see how we can differentiate between those patients who can have sudden cardiac arrest versus those patients in whom this particular ECG is fairly innocuous. Over a period of time, we do have a lot of publications since the 1992 publication of the Brugada brothers. To some extent, it has clarified things. To some extent, I think it has confused. One thing is sure, that this pattern seems to be more common in South Asian countries or the Asian countries than in Europe and North America. India and Sri Lanka do not feature here, primarily because we don't have publications from here. But I believe Asanga tells me that he sees about 10 every week. And just across the border in India, the whole of India doesn't see more than 10. Anyway, the Brugada ECG pattern is divided into three. Type 1 is the typical, that is ST elevation, a J point elevation of more than 2 millimeters with coving ST change in the right precordial leads with T-wave inversion. Type 2 is a saddle-shaped ST elevation, 1 millimeter or more in the right precordial lead. Type 3 is saddle ST elevation, but less than 1 millimeter in the precordial leads. Let's get things very clear here, not for the experienced cardiologists, but for the students. If you have type 2 or type 3, you are forced to do some studies or to do some maneuvers to see if the patient has type 1. And the maneuvers that you can do is to either take an ECG that is up to the second space, higher space, and then immediately, if you see here, type 2 or type 3 may show typical type 1. Or you do a drug challenge. The drugs that are used are edmeline, flecainide, preconamide, or piskinide. The one which is easily available and can be used, at least in India, orally, is flecainide. Worldwide, it is the edmeline which was tested first. Now, if these maneuvers and also on a ambulatory monitoring, because these changes can be transient, do not show type 1 at any point, then type 2 and type 3 are of no clinical significance. No clinical significance. It's only type 1 where you have to further see if this patient can be at risk of sudden cardiac arrest. So if you see type 2 and type 3 and you do whatever you can and it doesn't convert to type 1, you just forget it there. Also understand, just like long QT, there are a lot of medical illnesses and a lot of drugs which can cause type Brugada ECG pattern. What you have to remember, and I did very recently review an article for American Journal of Cardiology from the registry. They had very clearly shown that patients who have this kind of changes and then convert completely to normal over a period of observation do not have any higher risk of sudden cardiac arrest. Why I am saying this is that even patients with LQTS, first time come during a febrile illness or during drug challenge or having used some drug, that doesn't mean they are normal. So you need to withdraw or let them recover and then test again the ECG to see that they are absolutely normal. If they have reverted completely to normal, then that does not classify them as Brugada. All patients, regardless of other things that I'm going to describe, all patients with Brugada ECG must have, like I said, they must avoid all drugs, typically class 1 agents, and several other drugs which can induce a type 1 ECG because that worsens the ECG pattern, worsens the electrophysiological abnormality, and therefore can precipitate, just like in long QT, can precipitate ventricular fibrillation or ventricular tachycardia. Fever elicits type 1, and fever should be very carefully treated. Even if you consider these so-called Brugada and you subclassify as a low-risk Brugada patient, you must tell them to be under medical care while they are having a febrile illness. Again, of course, if they have syncope, they should contact a cardiologist. And all patients must have regular follow-up because, as I said, it's a progressive change. Some patients who start with type 1 may over a type 2 or type 3 may over a period of time go to type 1, where it becomes suddenly a little more serious. In terms of risks for sudden cardiac arrest, males are more prone than females. Patients who first present with a cardiac arrest are at more risk for recurrence cardiac arrest. Patients who present with syncope are about 25% as much as risk, and patients who are asymptomatic at first presentation are at the lowest risk, but not zero risk, and therein lies the problem. You have an ECG in an asymptomatic patient, it doesn't mean that he's at zero risk for sudden cardiac arrest. Spontaneous type 1, as I said, the patient has an ECG that shows type 1 is, you don't have to do any provocation. That is far worse than a patient who has type 2 or type 3 and who becomes type 1 on provocation. Thus an age predilection. It seems that the Brugada pattern and the Brugada clinical syndrome has something to do with the testosterone levels. Most patients present between 16 years and not later than 65 years of age. This is from the Brugada registry, the same thing. Most of them are males. The peak age is between 16 and 60, and the age at first arrhythmia event, again, is the same. So you're unlikely to have an arrhythmia event even if you find a Brugada ECG for the first time in an asymptomatic patient over 70 years of age. How do we manage? There is absolutely no doubt that if the patient is a cardiac arrest survivor, he needs an ICD. If the patient has syncope, and spontaneous type 1 ECG, the patient needs an ICD. Because as of now, ICD is the only, I'll come to some things later, but ICD is the only thing that can prevent death in these patients. What happens is that as you move to the other side of the graph, there seems to be a lot of confusion about what to do. Unfortunately, the patients in whom we are dead clear that we must put an ICD just form the tip of the iceberg. Majority of the patients, I'm sure Asanga would agree to this, majority of the patients fall in either they don't have spontaneous type 1 or are asymptomatic with type 1. What do we do there? Does an EPS study help? The Brugada brothers seem to think that patients with syncope and a positive EPS, that is, if you have ventricular fibrillation or ventricular tachycardia, induced at EP study predicts accurately future events. However, several other studies later on have not shown the same. So if you see on the whole at the total, there is no difference between, hardly any difference between EPS-induced VTVF versus those who had a negative EP. So a negative EP tells you nothing. It's the same with asymptomatic Brugada. One thing about an asymptomatic Brugada and a VT study is that if you have a negative EP study, that if you do stimulation protocols, you can't induce anything, they seem to have almost no event rate. So it has a negative predictive value, but if you induce, that doesn't mean that the person is going to definitely die of a sudden cardiac arrest. So EPS has its value, but it's extremely limited, despite it being a syndrome of sudden cardiac arrest. The other thing, again, that people have looked at is fractionation of the ST segment and also early repolarization changes. If you see the graphs carefully, actually the presence of fractionation clearly seems to differentiate between those who on follow-up had a sudden cardiac arrest versus those who did not. So instead of just looking at the ST elevation alone, look at fractionation of the QRS. The other things that have been described is the similar pattern. As I said, typically it is the right precordial leads. If you have the similar pattern in AVR, or if you have early repolarization changes, or if you have what is called peripheral Brugada pattern, that is Brugada pattern in leads other than the right precordial leads. All these add up and increase the chances of this patient having a sudden cardiac arrest, and therefore may be an indication for protecting them with an ICD, a defibrillator. Now, it's not very surprising if you see the mechanistic to see if the early repolarization having an association with Brugada pattern. because it's very simple. All these changes are a reflection of endoepicardial gradient in repolarization. If there's a gradient between the endocardium and the epicardium in the rate of repolarization and time of repolarization, if it occurs in the right ventricular outflow tract or the outflow part of the right ventricle, it produces the Brugada ECG. The same thing, if it occurs in the inferior leads, it produces the early repolarization changes. So they are actually Romeo and Juliet. So this is a summarizing slide, actually. So you have a lot of things, including spontaneous ECG, QRS from fragmentation, wide QRS, AVR sign, etc., etc. You see that a lot of them tell you or are seen in patients who have a history of cardiac arrest. But when you come to the other side, except for type 1, spontaneous type 1, there's a mixture. Many of them do not consistently tell you the chances of a future event. And that's very important because with limited resources in countries like ours and even the United States, you can't put ICDs in all patients. And these are children. And I showed you in the NEJM article, they did put an ICD, and putting an ICD or a device is not without its own level of complications. So unless you're very sure you're protecting against a sudden cardiac arrest, you're actually putting the patient at risk of complications of an ICD. So where do we come out from this puzzle? The best thing seems to be that if you have a ECG that is Brugada-like, combine the risk factors. If you are able to combine risk factors, 1, 2, 3 studies which looked at multiple risk factors, no risk factor versus 1 risk factor, 2 risk factor, 3 risk factors. So just don't look at the ECG. If you combine risk factors, including fractionation, including family history, including early repolarization changes, then that makes risk factor prediction or sudden cardiac arrest prediction much easier. And that perhaps is the way to go so that you keep the ICDs for those people who need it most and do not put it in children who do not require it. Before we end, so far, the only thing that acted in patients with the Brugada syndrome and at risk of sudden cardiac arrest, the only choice we had was an ICD. Increasingly, like in many other arrhythmias, we do have ablation procedures which are done epicardially in the right ventricular outflow tract, which totally reverses the ECG pattern and also decreases the need for an ICD or decreases risk for sudden cardiac arrest. I don't know whether Asanga is already doing it, but one of these days I want to learn ablation of Brugada from Asanga because he seems to be having more patients. This seems to be fairly simple, just like in WPW syndrome or so many other VTs that we know that ablation is curative. No device, just an ablation procedure. So in the end, Brugada syndrome is an important differential diagnosis for syncope and aborted sudden cardiac death in young adults with all structural heart disease. That's important. These are all young children, so you must know what to do and what not to do. Based on new criteria, Brugada syndrome, as I said, is diagnosed only if you have either spontaneous or induced drug or higher lead position ECG. Type 2 and type 3 are of no clinical value as of now. Symptomatic patients with sudden cardiac arrest or a spontaneous type 1 ECG plus arrhythmic syncope are at high risk and must have an ICD. Novel non-invasive markers like fragmented QRS complex in the right precaudal leads and signs of early repolarization in the infralateral leads might help you in patients in whom you are doubtful about the risk of sudden cardiac arrest. And last but not the least, ablation using three-dimensional mapping, which is available here in Colombo, does offer a dramatic new avenue for curing not only the ECG pattern, but the substrate, changing the substrate for sudden cardiac arrest. Thank you very much.
Thank you very much, Professor Dyer and Dr. Cooper. I must thank both of you for strictly keeping to time, which leaves us about 10 minutes at the end of the session for discussion. And I must also thank the organizers for selecting 3 very interesting and topical points, subjects for the discussion, and as evidenced by a very full hall as well. So to summarize, basically, we've talked about sudden cardiac death in ischemic heart disease population, then in athletes, and you've talked about the pre-participatory screening as done in the USA and the worldwide situation. And of course, finally, a very topical point again, the Brugada type ECG, which we always we fairly encounter in our practice and don't know what to do at that point. So you summarized that very well. I think Asang has some things to ask as well, but let me first start off this discussion about the Sri Lankan situation. So we have about 20 million population, and given the risk of sudden cardiac death of say at least 1, if you take it 1 per 100,000 population, we should have about 200 a year. But our figures are much less. So we have had about 6 to 8 maximum a year up until about 2012, 6 years back, at which point we introduced pre-participatory screening for athletes in Sri Lanka by a joint circular between the Health Ministry, Sports Ministry and the Education Ministry. Most of these deaths occurred during sports activities in the traditional Sinhala New Year around April, which is the thick of summer, and most of these activities involved cross-country running. So, we had about 4 to 6 deaths a year up until that time. So, in the pre-participatory screening, we made it compulsory for school children and also prevented children under 13 years from running marathons and made ECG compulsory for a pre-participatory ECG, compulsory for half marathons, marathons and more than 3,000 kilometer runs. So with that, you'll be quite surprised, the following year, that was 2014, the number of deaths was 0. So that was a major achievement. And that continued for about 2 years. So 14, 15, 16. Then last year, I think there were about 2 deaths. And this year so far, I have not heard of any. We passed that critical period, the April, the festive seasons. So this is how it is in Sri Lanka. And as you know, in Veneto, the Veneto studies and the Rome, or rather the Italian studies, they've showed a 90% reduction with ECG screening, which is attributed, as you mentioned, to genetic variations in certain populations for sudden cardiac death as well. So we were just talking about this.
And it's done at a low cost. Like in a sense, now you could get the ECG in dollar terms. You could get the ECG for $5. You will get the consultation if in the private sector for $10 and no fee in the government sector. And if you need echo, another $20. So basically for $40, we could get the whole screening done. Actually, we have picked up quite a number of children. The thing is quite organized. It generally goes to the general cardiologist, and if there is a doubt, they refer to the electrophysiologist, and we generally make the final call. And so since it's done at a low cost and it's proven effective, we think it's a good strategy.
That's right, yes. And it may be just isolated findings, but we've had 100% reduction basically over 2 years, then subsequently just creeping up. But that population is not really the targeted one with that circular. Lately we've seen in veteran athletes as well as the sports during activities during untrained people. So that sort of thing. Obviously, in international conferences on this subject, we've always questioned the Americans why they're not taking this up, ECG screening, and it's a cost issue, is it? Or do you think that evidence is not very strong for you to go for ECG pre-participatory screening?
Again, the data I know are mostly from Minnesota. there were 4 million patient years of exposure in Minnesota, and there was one cardiac sports-related death out of that the year when I was up there a few years ago. So I can't speak for the whole country, but at least for Minnesota, it appeared to be that the baseline rate was incredibly low. And of course, everybody gets a history and physical, of course, and usually more than one. I think it's they repeat every 2 to 3 years. They repeat it. Do you know for Sri Lanka how many confirmed cases of hypertrophic cardiomyopathy were diagnosed as part of the screening, or how many students were excluded from sports through the screening?
Unfortunately not, but we do have a registry maintained at the Health Ministry for the deaths, but we don't know how many have been rejected from taking part in sports after the screening. That is not centrally collected data.
We don't reject many. Actually, since we take on the theme that sports is so beneficial, we only restrict people from participating in highly active sports in only specialized circumstances, if there's a long duty or something like that. Otherwise, we would sometimes segmentalize and allow them to participate in certain sports. As you know, high-intensity football and basketball are not real sports in this country. So like those kind of deaths do not occur here. And so therefore, there is a fair amount of sports that people can participate and with the recommendations.
Yeah, we've suggested the Bethesda 36 guidelines as well as the ESC guidelines for once we diagnose for screening and rejection. But as he mentioned, sports is not that high intensity sports is not that much taken up, but these deaths occurred during the cross-country running mostly, during the cross-country running in probably untrained athletes. But I personally done some screening of professional Sri Lankan athletic teams in the Health Ministry as well as in the Sri Lankan police. Very recently we did a football team, national football team, the police team. And apparently now I had to do an echo, detailed echo of 5 pages, which is the standard now. It covers all the probable structural cardiac problems as well as the ECG electrical problems. So I think the World Federation of Football or whatever, they are quite particular now. We had to go through a very rigorous echo assessment for those 25 athletes.
Can I ask a small question?
It's true. The professional sports teams and the college level sports teams have their own screening rules, which include EKGs. I don't know every sport, but many of them do in the U.S.
Can I ask a question? I think it's a good debate on sudden cardiac death. So this is we get a lot of patients who have mitral valve prolapse, right? Especially children who goes to school and goes to sports, as well as army recruitment. We diagnosed for mitral valve prolapse. So what is your advice if you get a patient who is referred to you with a mitral valve prolapse? How do you advise on them on fitness to engage in sports and also to fitness in army recruitment?
Bhati, I think for Sri Lanka, we advocate the Bethesda 36 guidelines as well as the ESC guidelines on pre-participatory screening. I'm sure you all must be following the Bethesda ones for the American population. There is some little differences in some of the guidelines for various sports in the two. Overall, the Americans are a little more conservative, I would think, whereas the ESC, they are very particular not to send for sports. They are rather strict. So you can refer to that. The mitral valve prolapse is, of course, a wide spectrum. So depending on the degree of MVP, I think that clearly the guidelines describe what you should do. We'd probably like to know what, Dr. Cooper, what you would do in that situation. Mitral valve prolapse? No.
We wouldn't typically, asymptomatic mitral valve prolapse, we wouldn't block from sports.
Right. Any degree of mitral valve prolapse or mitral valve prolapse with mitral regurgitation?
Depending on MR. Again, if the echo was structurally normal, left atrium was fine, left ventricle was fine, the valve wasn't, dysmorphic or part of a syndrome, it would probably, we would let it go. If it was a syndromic, situation with other associated lesions, then you'd work it up specifically.
Can I add a comment? I think it's the same thing. We had this thing on the Asia Pacific Heart Rhythm Society, and we must all understand that it's a balance. If you do too strict a screening, you are keeping too many young children from going to sports. And in fact, the topic was, are we doing enough? Where do we stop? And what you say might be okay for a limited population, but when you talk about an APHRS, I think that except for competitive sports, and there also they say that stop at ECG screening, that's for professional sports, national level, and if the ECG shows up something, then goes ahead. So I think that we are pretty much like the Americans. I mean, if you do too many and then stop children from going to sports because of subtle changes, that's unfair to the child, because the event rate is really low. It's a tricky question, I mean, where to stop and how much to go.
I think in this country, there's something in favor of this scheme as well, because to put your child to a good school, the parents need to get involved with the school activities. So most of the doctors like to go and screen the children in those particular schools before sport activities. So it's fairly well established in the country over the past 6 years now. So
we have we have an unpublished paper that will be hopefully published in the next year. This is a paper that was focused on myocarditis, but that's not the point of the paper. You'll see in a moment. We did a study where people who came in with myopericarditis, chest pain, MRI positive myocarditis, were told to abstain from sports for 3 months. These are all athletes. They were given an exercise monitor to carry with them to measure their daily activity. And then at 3 months, they had a symptom-limited treadmill, and they all passed it. There were 42 people in the study, and they went on to be active again. So when we analyzed the data, a third of the people on their exercise monitor ignored our medical advice and exercised and participated without telling anyone. So I don't know, it's a very small study, but it tells you a third of people do what they want to do anyway.
Mohan, a quick question. Now we often find patients who have a primary device indication in the background of coronary artery disease undergoing CABG. And so the end result, what we see in the post-operative period is extremely stormy. They get atrial fibrillation, VT, VF, they get shocked out. Some of them do succumb to the event. The others do survive. And then at the end of it, there is a question like as to, where to address what the next step is. They get discharged after 10 days home. Sometimes we can't even put a beta blocker because there was a primary indication for a device. And what's your experience on this?
Yeah, you're saying that the first 48 hours was stormy, and I think we have the same situation. But if it is 48 hours or more, the first 48 hours is related to the acute ischemic event or the surgery. Beyond 48 hours, if they have arrhythmia, that's a primary indication. If it was in the first 48 hours, then if it is post-revascularization, then you are supposed to wait for 3 months, reassess, because that's the time the LV remodels, and put an ICD only then. But then also there is a gray zone, and that's why many of these patients in the US get a vest, because God forbid they have a sudden death at home. So they get a vest, but the indication is that post-bypass surgery, in the first 48 hours, or if the ejection fraction is low, you need to wait for 3 months before they fall into a ICD indication.
Okay, thank you very much for both speakers. for the excellent presentation and discussion. For the restriction of the time, we have to stop this session here. I would like to invite Dr. Asanku Dunil to give the token of appreciation for Professor Mohan Nair. I think Dr. Leslie Group already got his token of appreciation in the previous session. Okay, thank you very much for all the participation.
Thank you, sir, and thank you, chairpersons. With that, we conclude the symposium on sudden cardiac death. Moving on, the next will be a lecture on endovascular interventions beyond coronaries by Dr. Tarun Grover.
Co-chairs Dr. Amila Walawatha and Dr. Chaminda Kularatna.
It shows you so many things.
Respected chairperson and my dear colleagues, first of all, I would like to thank the organizers to have me over here to discuss about a topic which is I would say that I'm the odd person out because I'm going to talk about something beyond the coronary interventions. And what I'm going to talk to you about a unique class of stent, which is a Supera stent, and it allows to mimic the natural anatomical movement of certain vessels, so that it becomes a very viable option for dynamic areas like superficial femoral artery and the popliteal artery. So this is just a small celebration way back in August 2016 when we had placed our first Supera stent in the superficial femoral artery. And since then, the story continues, and we have been placing these stents for all the calcified long chronic total occlusions, which were very difficult to treat with the normal nitinol stents, or they had not have good results with the nitinol stents. And you would understand the superficial femoral artery and the common femoral artery and the popliteal, they are usually, I would say, exposed to a lot of stress, elongation, torsion, because there are two joints which are there, putting them to a lot of flexion, like the hip joint and the popliteal, the knee joint. So in these areas, you see in a common femoral area and the popliteal area also, these stents, they do very well. And space the final frontier, this was a very common phrase used in the era of the famous Star Trek serial. So I would say that Supera stent is also the final frontier for placing in the superficial femoral artery, because it gives us the, I would say, the best results comparative to all the existing modalities for treatment for superficial femoral artery. And till date, we have placed around 241 Supera stents in our hospital, which I believe is the longest single center experience in India. And how does this stent differs from the routine conventional stents? All of us, we know that the normal cell-expanding stents are solid nitinol tubes cut with a laser. But what makes this stent different is that this comprises of 6 closed braided interwoven nitinol wires. So what happens is that this gives a lot of flexibility without compromising the strength of this stent. And this is how the stent, the whole assembly comes. So it's a little different than the other stents, because normally what happens is when you have a self-expanding stent which is coming under a sheath, you withdraw the sheath and the stent starts opening. But here what happens is you don't have to withdraw the sheath. What you are doing is you are pushing out the stent from the sheath. And other very important aspect to understand about this stent is that normally when we talk about size, we talk about the outer diameter of a stent. We say, okay, we are placing a 5 millimeter, 6 millimeter, or a 7 millimeter stent. But we have to understand that when we talk about Supera stent, if we are talking about a 5 millimeter Supera stent, the OD of this stent is 5.5. So which becomes a very important factor when we prepare the bed of the artery by balloon dilatation before placing the stent. And normally the stent, when it comes loaded on the shaft, it is expanded 3 times of its length. So there is a definitive learning curve how this stent has to be deployed. And this you can see what happens is that how you can place this stent, and if there is significant calcification, then what you can do is you can stack the stent a little extra in that area to give additional strength to that area. So this is the advantage of this stent. So these are the factors how it has changed the rules of the normal conventional stent. It has got unparalleled levels of both strength and flexibility, minimizing the traditionally required design trade-offs. And it mimics the natural structure and movement of the anatomy, and it maintains the visibly round open lumen of normal healthy blood flow in the challenging anatomy. And now what has happened is we do get balloons which are half-size balloons, which means initially what used to happen if we were planning to place a 5 millimeter supera stent, then we were using a 6 mm balloon, which was little oversized for a vessel, but now we have a 5.5, 6.5, 4.5 balloons, so that we have an optimal sizing for placement of these stents. And you can imagine such significantly calcified vessels. Now these vessels were very difficult to negotiate and stent, and if you used to place a covered stent in this area, we used to lose all the collaterals. But the advantage of this stent is it doesn't get fracture, and you don't lose your collaterals in this area. And this has got significant flexibility. You can imagine this picture has been taken in the knee in a flex position. You see there is no kinks, there is no luminal compromise, and even it has been proven on IVA studies that there is no internal, the design of the stent doesn't get distorted even on flexion and various movements. And here you see, so how this stent is better than all other stent is because this has got 4 times more compression resistance and the lowest chronic outward force, which means rather than resisting the vessel, it supports the vessel. So once it supports the vessel, there is a minimal chances of having a neo-intimal hyperplasia without getting the stent kink in these areas. And this is just one non-SFA use of a supera stent. I just wanted to highlight how good this stent is flexible. This patient is a follow-up case of a polytrauma. This patient had a right elbow fracture and he had developed a pseudoaneurysm with an AV fistula. So a covered stent was put. So this patient was doing fine, but suddenly he had a thrombosis of his stent and acute limb ischemia. And post-thrombolysis, what we realized, there was a significant kink in this area. And this kink was again treated with placing a supera stent. And you can see the dynamics even under complete flexion more than 90 degrees at the elbow. There is no kink in the stent. And this patient is doing fine now. And there is a definitive learning curve because when you start placing these stents, what happens is either there is a possibility that you have a shortening or you have elongation, which definitely affects the long-term patency of this stent. So it's very essential to learn the proper deployment, and that comes with experience. It's not very difficult because you can see this is almost an optimal deployment of a supera stent. And there is a significant evidence available. SUPERB was a multi-centric, I would say, prospective study involving more than 34 centers in the US, and they said that vasculomimetic stent is the treatment of choice for highly calcified long SFA disease. And it has shown significant benefit as compared to all the current SFA treatment modalities, except it is a permanent implant. Otherwise, it overshines with all the existing treatment modalities. And these were the results which were very, very promising, almost close to 86% patency at the end of first year with 0 fractures, which was very, very important because fractures in this area is the major concern. And at the 2 years, the freedom from TLR was almost again close to 84%. And other important thing which came out of this study was that usually what happens is when you are talking about the SFA lesions or the peripheral vessel, if you have a longer lesion, the patency get compromised. But this didn't happen with this stent. Even the longer lesion, the patency was almost equivalent to if you were treating a small lesion or a long lesion. And this is the data from our center. The majority of stents have been placed in the SFA and popliteal area. But we have used in certain areas because we have improvised with our experience. Though this is out of the IFU, we have placed these stents in the iliac, axillary, and brachial. I'll show you some cases. And the results have also been very promising as compared to the world literature. We have significant wound healing, ABI improvement was significant. We have no fractures. We do had significant patients who had occlusions also, because these patients have a very aggressive atherosclerotic disease, poor runoff. Sometimes they continue to smoke. They are not compliant with the medication. So all these factors, they play important. Now, other important thing to understand is what proper sizing, vessel preparation, and deployment technique. Because if there is a elongation or there is a shortening, then it affects the patency rates. So it's very important to know that how to deploy these stents properly. And in our study, the lesion length varied from 6 centimeter to 23 centimeter. Minimal elongation was observed in only 19%, moderate in 8, and 3 patients even had shortening of the stent. And we do develop neointimal hyperplasia in these patients also. You see, if you see this patient who was under surveillance, and at 13 months, he had started developing a neointimal hyperplasia, and this was treated with a drug-eluting balloon, and you can see the image post-balloon dilatation. So how do you master the technique? The most important, the 3 keys for optimal superior deployment are proper pre-dilatation, which means you have to prepare the bed properly. If you are placing a 5 millimeter, then you do have to dilate the artery with a 5.5 millimeter balloon, which means size 1:1. It doesn't mean that if you are placing a 5 millimeter balloon, you inflate a 5, you put a 5 millimeter superior stent in that. And deploy slowly. That's very important, that you see what's happening to the proper geometry of the stent. You magnify the fluoroscopy, you see what's happening. A lot of people in their initial experience, what they used to do, they used to place a superior stent across the leg so that they used to see how the normal geometry is when they're placing the stent, so that they could match the fluoroscopic images of a correctly placed superior stent. And these are some of the off-label use where we do a lot of hybrid recanalizations, because we have patients who have long iliac occlusions, and there is no distal reformation of a common femoral artery, which means you only have a retrograde filling profunda. So what we do is we open the common femoral, we do an endarterectomy, and then we place a stent. But what used to happen with the self-expanding stent, as they used to cross the inguinal ligament, they used to get fractured. But this stent has really helped. And mind it, these are all patients who are having significant critical ischemia, the limb is at threat, they are elderly. So basically, these are all salvage procedures. These are not elective procedures for young adults. And flexibility is excellent. You have areas like subclavian artery where there is a chances of getting the vessel crushed between the rib and the clavicle. So this stent really does very well. Retrograde deployment. Now what happens is, suppose you have a disease which is starting from the SFA ostia. Now, SFA ostia or the common femoral artery, they were considered as traditionally as a no stent zone. And the problem with supera is that if you try to place them, you are not sure where the distal end will land. So in case you have to deploy a stent which has to start from flush from the SFA ostia, you can't have coming from the brachial artery or from the contralateral groin. So which means you have to do a retrograde deployment, and this is how a retrograde deployment is done. We use tibial vessels, we have used popliteal artery also punctures for deploying these stents. And once you have nice image and you have clearance. So you just imagine something like this, a patient who has a femoropopliteal disease, has an SFA ostial disease, has a long segment chronic total occlusion of the SFA. Traditionally, this patient would have required a femoropopliteal bypass. But by placing a superior stent in this patient, you avoid doing a surgical intervention, and you have a reasonably good result in these patients. And long iliac CTOs where you have reformation of the common femoral artery, we have done these patients totally endovascular without making any cut. So you have seen superior stent along the iliacs, and they do really well. We are following up these patients. Hopefully we should be coming out with our experience in a form of a publication, because our center has done the maximum number of iliac superiors in the world. And this is really totally a different areas where you have long total occlusion of the bilateral iliacs within distal aortic occlusions. These patients, if at all, were subjected to endovascular reconstruction. They used to be called a CRAP technique, which was a covered endograft of aortic bifurcation reconstruction. But again, we have done these procedures with the help of supera. These patients would have landed up with something like this, a conventional aortobifemoral or aortobiiliac surgery with a long incision. But what we have done is, just by a simple brachial puncture, we have got these stents placed in the vessels, and once you have totally a reformed bilateral aortoiliac segment, which is nice. Again, a difficult case with a total distal aortic as well as long iliac occlusions. And what we have done is we have just used one brachial puncture for placing all these stents. So what we use a 7 French sheath, and then we use a buddy wire, 014 wire, and then recanalize one iliac, then don't lose the buddy wire, use another wire to recanalize the other, and then you place your stents simultaneously. So what you end with, you placed one supera and one self-expanding on each side, so that you have, so you place the supera in the area where you expect a lot of flexion and torsion, and then you can, because later in the proximal common iliacs and the aorta, you can end the procedure by placing your self-expanding stents. And this was the problem which we were facing with the self-expanding stents. Despite the good, I would say, flexibility of the existing stents, they used to definitely get fractured. So what we started doing is we have started placing superas, and this patient was again salvaged by putting a supera stent across the stent fracture. And these days, everybody is excited about the FIFA World Cup. I would say it's not only the Beckham who can bend it. So this stent has not disappointed us in showing the conformability to various vessels. And this is again a patient who had an axillary and brachial, and you can see this bends significantly. And so it doesn't disappoint any of the anatomical situations which are very, very difficult to overcome. And so I bring greetings from my hospital, which is Medanta Medicity, one of the, I would say, the largest private hospital in India. And this is our team and our department. And there are plenty of learning opportunities for young, I would say, fellows who want to come and learn. We do conduct a lot of workshops, and we do have hands-on training on simulators for peripheral interventions. We do a lot of workshops for peripheral vascular suturing also for all the surgeons who want to learn certain suturing. And we do high amount of venous work, which involves endovenous laser ablation as well as CDT for deep venous thrombosis. And we're doing close to 70 to 80 cases. So anybody who's interested is more than welcome to come and visit our center. Thank you so much.
Thank you, Dr. Grover. Just one question, since we have left with some time. How does the patency rate compare with bypass surgery, peripheral bypass surgery?
I would say surgery, being surgeon, I am definitely a little biased towards surgery. So surgery is a gold standard for especially long chronic total occlusion. So it's not that these techniques should be done in every patient. So these techniques should be reserved in those patients who are not fit for surgery. These are salvage procedures. But for the superficial femoral artery, if there are mid-segment disease, these stents also do very good as comparable to conventional bypass grafts. But definitely for the aortoiliac segment, if the patient is fit for surgery, surgery should be a first option for these patients.
Yeah, thank you very much for your excellent presentation.
Thank you.
I would like to invite my co-chair, Dr. Amila Valawat, to present token of appreciation to Dr. Tarun Grover.
Thank you, sir, and thank you, chairpersons. We now move on to the last symposium for the day, Symposium on Hypertension.
Co-chairs will be Dr. S. Mitrakumar and Prof. G.R. Constantine.
Yes, good afternoon. The next session is on hypertension, a symposium. The first talk will be delivered by Professor Alistair Hall on update on hypertension guidelines.
That's what I like, a short introduction that gives me more time. Thank you. It's my first visit to Sri Lanka. I arrived yesterday and I like to walk. So hopefully that's all right with you. You can still hear me. It keeps me awake. I had a big crab dinner at the crab factory, so I need to walk. So I have a very good friend, Professor Mohan Sivanathan, who is from Sri Lanka and for many years has said it's the best place in the world, paradise. My impression so far is that he's right, but I've seen the palm trees, this hotel, and I've really enjoyed the respect you give to education. I think it's amazing, actually. In my own country, we have difficulty sometimes getting people to come to events. So thank you for coming. It's a real great accolade, I think, to your country that you're in this place. So I'm going to talk about hypertension guidelines. Over the crab dinner, we did discuss the value of guidelines, maybe some of the controversies. So I only have 15 minutes or so. I'll give you a little bit of a flavor of what's changed. But the short story is treat to a lower target, start earlier, and probably use a combination therapy first. Don't go through the one tablet. That's the summary. So where I come from, I am a clinical director of a research network, and we're asked to solve the problems of the UK, which is an aging population by the year 2040. So we have 4 strategies. The first strategy is we're going to make a new discovery which is going to stop people getting old. We're not waiting too long for this, but okay. The second strategy is personalized medicine. Choose your patient with a clever test and then just treat them, everyone will be fine. Third strategy, best treatment as routine. Everyone gets the therapies we know work, but currently maybe they don't get it. This is where the guidelines probably come in. And then the fourth strategy, which is the one I favor, health of the public. We heard something about that yesterday from the World Heart Federation, that we need to go to a primordial prevention, meaning get it integrated into our way of living. So I'll start with the NICE guidelines, which NICE is National Institute for Clinical Excellence, set up to improve the routine care of patients in the UK. We need to find a person, measure their blood pressure. We have to find them first, measure it second, diagnose the problem. We know a percentage are not picked up, a percentage are not diagnosed. In this country, as in ours, a large proportion. But having diagnosed it, we have a clinical target of 140/90 if you're less than 80, or 150/90 if you're above 80. So we have a little bit of age coming in there. And then we have a slightly different level if we're doing it by continuous ambulatory monitoring or home measurements, which are recommended. It's 135/85. We measure cardiovascular risk because we're keen to know that. Target organ damage is assessed, and then we manage with lifestyle medication, and other is advanced therapies. I won't talk about those. Lifestyle, I'm going to spend little time on, although it's the most important. And then we optimize, meaning we do titrations, we do adjustments, we talk about medicine adherence, and then we review these patients. We have a primary care system which is very good at this process. And I think overall, hypertension is well managed in the UK. You'll know that the value of a 24-hour reading is that sometimes people have a white coat hypertension where when you measure it outside of the clinic setting, they don't have it. We have masked hypertension. I had a patient who was referred with resistant hypertension, normal pressure. I said, "Did you take twice your tablets today?" She said, "How did you know, doctor?" Lucky guess. So people will mask their blood pressure, and then you may be misled into decisions. I'm not going to go through the use of 24-hour readings, but I find it particularly helpful with sleep apnea as a driver of hypertension. A lot of people have obesity and they're snoring in our country, so we may correct that and improve the blood pressure. We have a stepwise approach which begins with ACE or ARB, calcium channel blocker based on age or ethnicity. I think we're probably slightly unusual in that regard, but we then combine A with C, and then we go ACD. Then we declare it resistant, we get on to other therapies such as spironolactone. These are my personal choices, and I'm prepared to declare my interests. My interests are, for my entire professorial career and before, I worked with ACE inhibitors. First of all, ramipril. And I am an advocate and a champion, but it's within the guideline, A, either, and then, of course, B, C, D, as we've seen. What's interesting is B dropped off the guideline, beta blockers. We don't have it in our guideline as a first or second line. It is used in conjunction with angina, for example, or palpitations. This is the European guideline. You can see the tower change. We're now in Paris, and we should choose between single or dual. We could start with dual agent for more severe grade 2 hypertension. We're going to come to the new guideline where we can use it also in normal. But then we're going to go with a single or a double agent, and we're going to do titrations. But when we're finished, 30% will be on one drug, 40 will be on 2, 30 will be on 3, and this is with a target of 140/90. As soon as you lower the target, more than 70% of your patients will need 2 drugs or more. So this is one of the key messages we're going to touch on. In that guideline, it says if you're going to use 2 drugs, look at the trials, see what was effective, see what are the disease, and then choose. This is the guideline. You will choose. Here we are. Choose. There's many trials, many combinations, and I think here, as well as in India, where I'm going next, with all the generics and other things, thousands and millions of choices. So it's tricky. Are they all the same? They all lower blood pressure? Is that all that matters? Well, I think the answer is no to that question, but we'll come on to why I think that. But all of these are lowering blood pressure. We can see, if you could see the details, some trial outcomes. We're told ACE and ARB, no combination recommended by any guideline. But this is a bit like a league table, only they haven't played football yet. This is before the football is played, so what we need is a bit of a football game. Here we have amlodipine, perindopril, atenolol, thiazide in Ascot. This team is scoring 4 goals, primary endpoint reduced, death reduced, MI reduced, stroke reduced. This team is 0 or -4 goal difference. So if I'm now asking you to choose, which are you going to choose? This is an easier choice. You have one choice to make. And, you know, England lost to Iceland in the last competition. And Iceland is a very poor team. One English player is worth the entire Iceland team on the market, but they won. So we know football and maybe trials could be wrong sometimes. We need lots of games. We need a World Cup. So if you look at the World Cup of combined therapy taken from the European guideline, how did they do? Was the primary endpoint reduced? Yes, in the first column. Was MI reduced? Yes, in the second column. Stroke, sorry, that's death, MI, stroke. And then here are the no's. This is the bottom of the table where we have placebo, 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 placebo. But look, valsartan, thiazide, in value, increasing MI. One of the main combination therapies used throughout the world. I don't understand it personally because this is how I look at the data. I'm not saying blood pressure is not lowered. I'm telling you that the thing that matters to me is mortality, stroke, and MI. So when we look at that, we can see at the top of the table, we have amlodipine, perindopril, indapamide, perindopril. That's why they are my selected agents. Nitrendapine, captopril in a Chinese study, indapamide, perindopril in the progress. And as we come down the table, you can see the ACE inhibitors, calcium channel blockers are frequently there. We've got a few thiazides mixed in there. We have 2 ARBs making the top half of the table. Down here, we tend to have the thiazides, the beta blockers, short-acting ACE inhibitor. We've got valsartan there. So the question is this a basis on which to choose? Remember what the guideline told us. It basically said, find an effective trial. Think of comorbidity. So in summary, these are the effective trials, these are the less effective options. And we can choose. The question is, on what basis do we choose? Do we choose on mortality hard endpoints, which is my preference, or are we choosing for some other reason? So the new European guideline says start with a single pill, 2-drug combination. That's very advanced. And these are not fully published, they've just been announced verbally. So the idea behind this is we're going to end up on 2 or 3 tablets. We've got a lower target, 130/80. We're going to need 2 or 3 tablets. That if you use a 2-tablet approach or a 2-drug, 1-tablet approach, we can use lower levels, which is better for side effects. And it's synergistic. Blood pressure is like a mouse. If you try and catch it from one direction, it runs away. If you try and catch it from 2 or 3 directions, you can control it. If you give a diuretic, you increase renin-angiotensin. So you're going to need to balance these things out. So I think that's behind. Now, I use the iPhone as the example. Before I had a watch, I had a diary, I had a camera, I had a pen, I had many things. Now I just carry one thing. And I think patients are expecting simpler therapies in terms of this combinations. If you run out of one, are you going to wait till you run out of two before you get the prescription renewed? These are some of the practical issues. So if we see, this is an example of peripheral amlodipine, but given a single tablets, and this is either, so one of the two, and we just look at the effective time, there's a reduction in medicine adherence. That means they don't take their medicines. But if we change it for a fixed combination, again, they're starting on single pill or just one or the other, we see an improvement in medicine adherence. So this is behind the advice of the European guideline. They've looked at meta-analysis, fixed dose combinations, free combinations, and they feel it's an important issue. Because the two biggest issues they think are, one, medicine adherence, are people taking their medicines? Two, clinical inertia. Clinical inertia is us, when we're spending a long time controlling the blood pressure, we, in a sense, give up, as well as the patient. Too many titrations, too many switches, and so earlier control is believed to be important. This is an observational study, but it makes the same point. Continuation is more likely with a single than a double pill, and then they suggest it does have a knock-on effect on hard endpoints in an observational study. This was not a randomized study. So the American guidelines, you probably heard, here's the Empire State Building, a new target of 120/80. Now this is exciting for me because I'm an epidemiologist and I know that there are people who live in South America whose blood pressure throughout their life is less than 100 systolic. They go through life with a low blood pressure and they're not ill, but they don't get vascular disease. If you do a post-mortem at death, they haven't got fatty streaks and these other things. So I think the natural blood pressure of all of us is lower than we classify as average or normal. So bringing it down is based on a study called SPRINT, where the blood pressure was either brought down to 120 or kept beneath 140, the old target, new target, 3 drugs, 2 drugs, and total mortality was reduced in this group of high-risk patients. And this, of course, has pushed us further in the direction of lower targets, which brings its own problems. But if we take a global perspective now, this is in the Emirates, but it's, I think, the world's tallest tower still, so it's representing the world today. We have health, elevated blood pressures, organ damage, events, and either they occur in an accelerated pathway or a very slow, people stay healthy till old age, and then, I don't know, they trip over something. And of course, this is actually a cheaper life in terms of healthcare, the area under the curve, than are some of these, even though it's longer. So a longer life is not more expensive if it's healthy. That's what we need to be aiming for. At the moment, we're converting people from early to maybe average life courses. If we're going to go that bit further, it's going to take drugs that can extend life, basically. So I believe ACE inhibitors are one such class. You'll know the pharmacology. It's blocking all of the angiotensin receptors by blocking higher up. Beta-2 is stimulated bradykinin. We've seen MI and stroke reduced. The ARBs, which tended to be at the bottom end, are blocking AT1, stimulating these, doing nothing there. And we're going to see that although they reduce stroke, there's no evidence on MI or death. Having said that, there are analyses like this that say, look, they're equal. Cardiovascular mortality, stroke, ARB versus ACE, less side effects with ARB. Use an ARB, same benefit on mortality, but easier to tolerate. I think that's what we call a type 2 error. Type 2 error is where you go against a weak opposition, the grandfather. You know, the son fights the grandfather, so we got the new ARBs against captopril in those 4 studies, and it's a draw. It's set up to lose, if you like. We could talk about on target how that's all equal true. The real test is, can you beat placebo? And ARBs have never beaten placebo, even on the primary hard endpoint where it's combined. They have done it on stroke, but they haven't done it on MI or death. So that's the real test. This is shown in a meta-analysis. On the right, no superiority versus placebo. On the left, superiority versus placebo. So I think that evidence is clear. But if you were still in doubt, the most recent ARB data from the HOPE-3 study, candesartan thiazide versus placebo, so that's 2 versus no drugs. Blood pressure was lower with the drugs, And before this was published, an editorial said, we don't need this study. We know lowering blood pressure lowers events. We don't need this study. We already know the result. But they were surprised. The result was no difference. In spite of 2 drugs, in spite of blood pressure lowering. This makes, again, and there's many other studies that make the point that lowering blood pressure alone is not enough. You need to prevent events as well. So this is me redrawing that graph. ARBs is similar to placebo on hard endpoints, but I've made it a lot safer. This is my graph. It's plagiarism of sorts, but I'm trying to illustrate a point. If you think that ARBs and ACE are equivalent, then you must also believe ARB and placebo are equivalent, and placebo is cheaper and better tolerated, if that's your concern. So in Sri Lanka, I'm told that nearly 1/3 of the population, this is based on this group, have got hypertension. 78 of those with hypertension on treatment are not hitting targets. It's no different where I come from. Okay, maybe the numbers are slightly different. The problem is the same. And hypertension has been here for a long time. And we've had lots of drugs and lots of time to research and think about it. We're still not where we should be. This same paper tells which combinations are used. I've put the middle 2 as the ones I would consider to be most strongly evidence-based. The top 2 have a beta blocker, CCB, beta blocker ACE. I can't show you even one trial where that worked. They may lower blood pressure, but I can't show you hard endpoints. And if you remember what I showed you, we can see that the ACE, CCB, ACE diuretic is up there at the top, although it's not all ACE and it's not all diuretic, but that nowhere on that list is BB, CC, BB, ACE. So there's a real question for you as doctors. Why would you choose that combination? Maybe it's angina, maybe it's palpitation, maybe there's a good reason. There can be, but overall, it's not with the evidence. So we must remember, everyone's arteries are aging. We're going to find out more about this in the second presentation, but our job when we treat hypertension is to keep the arteries young longer. That's what I tell my patients. It's not about the thing in your arm, it's the thing that we can't directly see. This is an indirect indicator, aging of your arteries. And we need to start that early in the life course with lifestyle adjustments and so on. So I think I've used all my time. I get to come again. I don't know whether you see, but I'm also the 3rd speaker. I apologize to you. I might change my suit. Maybe I'll change my accent. Maybe I'll stand behind here so you can think it's a different speaker. But I take it as a bit of a continuation of what I've been allowed to do in these first 20 minutes. So we'll develop some of these ideas a little bit more shortly. But thank you for those opportunities.
Thank you very much.
Questions? Yeah,
we will have the questions at the end of the session. Thank you very much, Professor Alistair Hall. And the next speaker is Professor Andrew Boyle. The topic is hypertensive emergencies and urgencies.
Okay, thank you very much. Thanks to Dr. Mubarak for inviting me, and to Dr. Bhatia Ranasinghe and Chaminda Pushpakumara and the rest of the committee. It's a real pleasure to be here again. This is going to be quite a different talk because I'm going to talk about something that has absolutely no evidence whatsoever. So I won't have all those tables of randomised controlled trials, because hypertensive crises, there are virtually no randomised controlled trials to guide us whatsoever, just some principles that we can talk about. And I'll be standing behind the microphone, not walking around like Alistair. Okay, so we don't see hypertensive crisis every day, but it is an important clinical problem. As already mentioned, much of the adult population worldwide has hypertension. Estimates vary from country to country, but safe to say it's above 20% of the adult population in most countries. And that means it affects over 1 billion people. Hypertensive crisis affects 1 to 2% of the hypertensive population over their lifetime. So if you do the math, that's 10 to 20 million people at least that will suffer hypertensive crisis. Let's start with the definition. Hypertensive crisis has been defined by the JNC, the Joint National Committee on Prevention, Detection, Evaluation and Treatment of High Blood Pressure, in JNC 7 as a systolic blood pressure of above 180 or a diastolic blood pressure above 110. It's further subdivided into 2 categories: hypertensive urgency, which is acute severe hypertension without any signs of end organ damage, and hypertensive emergency, which is acute severe hypertension with signs of end organ damage. And those end organs predominantly are the heart, brain, aorta and kidneys. There are other classification systems that have slightly different endpoints, but they all have an acute severe hypertension as the underlying diagnostic. And this is important because the way to treat hypertensive urgency and emergency is slightly different. So the first practice point is if you have hypertensive urgency, even with very high blood pressure and no evidence of end organ damage, the goal is to lower the blood pressure fairly urgently within the next few hours to days. And that can often be done safely as an outpatient and with oral medications, and there's often no need to admit patients to hospital or intensive care. And in fact, the JNC document itself admits that the term urgency leads to probably an over-treatment effect in patients without end organ damage. Practice tip number 2, in hypertensive emergency, this is a true emergency. These patients need to be admitted to hospital, preferably in an intensive care setting or an HDU setting with invasive blood pressure monitoring. And the goal here is to lower the blood pressure acutely in the first 1 to 2 hours. Hypertensive crises can occur in essential hypertension or in secondary hypertension, but it's far more common in essential hypertension. Non-compliance with medications or just inadequate medications are by far the most common cause of a hypertensive crisis, which is our fault, and also the patient's fault with non-compliance. And to put some numbers around that, there was a cross-sectional study in Brazil that showed 88% of patients with hypertensive crisis had a pre-existing diagnosis of hypertension, and 76% were already on medications. So we like to think of exotic and esoteric causes of hypertensive crisis, but by and large it's plain old garden variety hypertension that's inadequately treated. Any of the causes of secondary hypertension can present with hypertensive crises. Endocrine disorders, renovascular, I won't go through them all, but there's a few down the bottom there that are important because they are acute and severe, and that is drug-induced hypertension, eclampsia or preeclampsia, head injuries and burns. And when hypertensive crises occur without pre-existing hypertension, they can often occur at lower levels of blood pressure with evidence of end organ damage. The pathophysiology of a hypertensive crisis is a vicious feedback loop where high blood pressure leads to autoregulation failure, or failure of the normal vasoconstriction, vasorelaxation in organ beds. There's increased resistance, and the vascular beds, to protect themselves from the barotrauma of blood pressure, vasoconstrict. And this results in a feedback loop where the vasoconstriction worsens the high blood pressure, and you get into a negative spiral. The barotrauma also causes endothelial injury, which can lead to a prothrombotic state and ischemia of the organs. And the vasoconstriction leads to renin-angiotensin system activation, which again causes more vasoconstriction and worsening of high blood pressure. So that vicious cycle has many components, but they're consistent throughout. The target organ dysfunction mainly relates to the brain, heart, aorta, the eye, and the kidneys. In the brain, that can present as a hypertensive encephalopathy, or something as simple as a headache, or it can be more pronounced with drowsiness or even a coma. There can be seizures. Can even present with an ischemic stroke or a hemorrhagic stroke. In the eyes, it can present with a hypertensive retinopathy or retinal hemorrhage. And the heart, there can be angina pectoris or even acute myocardial infarction, but heart failure is probably the most common manifestation. And the kidneys can present with renal failure. So these are the target organs to really be thinking about when seeing an acute severe elevation of blood pressure. To divide it into a hypertensive urgency or emergency will guide your treatments, and therefore a thorough clinical workup is really necessary. On the left, it might be a bit small to read, but if you think about it going through the target organs, you want to ask about visual disturbances and examine the eyes with fundoscopy for hypertensive changes and papilledema. Thinking about the mouth, ingestion of drugs which can cause acute severe hypertension or non-compliance with their antihypertensives. In the heart, you want to know about chest pain, of course. You want to know about orthopnea, paroxysmal nocturnal dyspnea and shortness of breath. And the kidneys, you want to know about blood in the urine, oliguria, anuria, urinary retention, particularly in elderly males, as a cause of renal failure leading to hypertensive crisis. In the CNS, you want to know about stroke symptoms. symptoms of hypertensive encephalopathy, and headache. We want to know about chest pain, and particularly the character of the chest pain. So a tearing chest pain that radiates in between the scapulae would be suggestive of aortic dissection in the setting of acute severe high blood pressure. Some tests, you want to start with some basic tests, an electrocardiogram, troponin and B-type natriuretic peptide. Chest x-ray would be a sensible thing to start with, and an assessment of renal function and urinalysis for proteinuria and blood in the urine. And fundoscopy should be mandatory. And then depending on the symptoms and the signs, you could go on to do other tests like a CT or MRI of the brain if you suspect a stroke or a cerebral hemorrhage, an aortogram if you suspect dissection, a urine drug screen, cocaine, methamphetamine are very common causes where I come from. And if there are secondary causes of hypertension suspected, then the test's appropriate for that. If we think about the brain as the end organ affected by hypertensive crisis, it's quite a complex situation where there's neurological dysfunction in the context of a severe elevation in blood pressure. And there are several important differentials. So stroke, cerebral hemorrhage and brain injury can be the cause of the hypertensive crisis. Stroke, cerebral hemorrhage and encephalopathy could be the consequence of elevated blood pressure. And it's important to get the history or corroborating history and test results to differentiate between these two. Now, the concept of cerebral autoregulation is really fundamental here. The diagram on the right shows cerebral blood flow versus arterial pressure. And there's an optimal level of cerebral blood flow below which there's inadequate flow and abnormal CNS function, and above the inflection point there's excessive cerebral blood flow leading to acute and chronic problems with the brain. And you'll notice in red that curve is shifted to the right in chronic hypertension. And so that zone of blood pressure where there's optimal blood flow is at higher levels of blood pressure. And that somewhat protects the brain in chronic hypertension for elevated blood pressure. But it's also very important when you lower the blood pressure, that negative inflection point where there's inadequate cerebral blood flow is at a much higher point in people with chronic hypertension. So practice tip number 3, in hypertensive encephalopathy, the aim is to acutely reduce the blood pressure by 20 to 25% and no further than that. If you drop the blood pressure too acutely, you'll get into that zone of inadequate cerebral blood flow. And so that aim should be achieved over the first 1 to 2 hours. And then you want to stabilise the blood pressure around 160 over 100 before we can change on to oral medications. The caveat to that, however, is acute ischemic stroke. And that's the one CNS problem with acute hypertensive crises where you want a higher blood pressure. We know that the outcomes from stroke are worse if your blood pressure is too low or too high, and permissive hypertension is in the guidelines. So you only treat blood pressure in acute ischemic stroke if it's above 220 millimetres of mercury, or you treat to below 180 millimetres of mercury if you think they're a candidate for thrombolysis. Cardiac dysfunction is as common, or perhaps more common, than CNS problems with acute hypertensive crisis. The severe hypertension leads to an increased afterload, which the ventricle then develops an elevated end diastolic pressure in response to. That pressure backs into the left atrium. Left atrial pressure is transmitted back to the pulmonary veins, leading to shortness of breath, pulmonary congestion, and all the symptoms of heart failure, and even frank pulmonary edema. But despite the pulmonary edema, it's usually not a problem of fluid overload, particularly when this is very acute. And so diuretics are not the first-line therapy. Nitrovasodilators, which reduce preload and afterload, therefore the left atrial pressure and the systemic blood pressure, have immediate symptomatic benefit. So practice tip number 4, for acute heart failure in hypertensive crises, nitrovasodilators are the first choice. This is a table put together by the Heart Failure Society of America, and what they say is that the stepwise approach is to maintain oxygenation, initially with oxygen, or maybe even non-invasive ventilation or intubation. And they also say at the top, give sublingual nitroglycerin in the emergency department, because that's rapid. You can get one of those under the tongue pretty quickly. And if the blood pressure remains high, intravenous nitroglycerin or sodium nitroprusside. So nitrovasodilators are the first agent. And then they go on to say loop diuretics can be used but in the right column, initiate nitrates first. Aortic dissection, probably the thing we're all most afraid of in acute high blood pressure. The classic symptom is tearing chest pain radiating through to the back, and that's due to shear force or stress on the endothelial lining of the aorta by high blood pressure, allowing blood into the subintimal space. And the high blood pressure propagates that tear, and blood creates a false lumen, leading to all the complications that we all know about. So the therapy there should be aimed at reducing shear stress as well as blood pressure. And in this situation, vasodilators can increase shear stress and make the dissection worse. Aortic dissection is another area where you don't want to just go for a 20% reduction in blood pressure. Because it's a life-threatening emergency, aortic dissection, the aim is to normalise the blood pressure as rapidly as possible, or as rapidly as tolerated, down to normal levels. So practice tip number 5, for aortic dissection, beta blockers, which reduce shear stress, are the first line of therapy. And only once people are maxed out on beta blockers would you go to a vasodilating agent. So let's go through some common scenarios. And I'm sorry, I don't have a pointer here. It'd be nice to have a pointer. But what have we got? I've got a few minutes left. So an acute ischemic stroke, if you look at the clinical scenario in the left column, and then in the third column, the drug options, for acute ischemic stroke and hemorrhagic stroke and hypertensive encephalopathy, the recommended first agents are intravenous beta blockers. And something short-acting like esmolol or a non-selective beta blocker like labetalol would be good options there. And in the fourth column, you'll see you should avoid nitroprusside in the CNS situation because it can worsen cerebral edema. In acute heart failure, the opposite is the case. Nitroglycerin or nitroprusside should be first line, and beta blockers and calcium channel blockers can cause acute reduction in inotropy and make the clinical situation worse, so they should be avoided as the first line. In acute aortic dissection, labetalol first, and once beta blockers are maximised, then you can go on to vasodilators. And then down the bottom, we've got some more specific situations like eclampsia, where magnesium has a role in acute severe blood pressure, beta blockers, and then the definitive treatment of delivery. And then sympathetic crisis and pheochromocytoma, it's important to have alpha blockade as well as beta blockade. So if you give beta blockers first, there's unopposed alpha stimulation, and patients can get worse. So phentolamine is first line for alpha blockade, followed by beta blockade in that situation. So practice tip number 6, the pathophysiology of the end organ damage or the cause of the hypertensive crisis should guide your choice of antihypertensives. Okay, so I'll finish by summarising the 6 practice tips and an absence of randomised controlled trials. Hypertensive urgency, the aim should be reduce the blood pressure in hours to days. Oral medications are usually enough, and this can be safely achieved as an outpatient. Hypertensive emergency is an emergency. The patient should be admitted to hospital, to a high dependency unit or an intensive care unit, with an aim to reduce the blood pressure to a safe level within hours. An initial reduction of 20 to 25% is suitable for most hypertensive crises, particularly the hypertensive encephalopathy, and then change to a more slow oral agent regimen. But for acute heart failure, nitro-vasodilators are the first line, and for aortic dissection, beta blockers are the first line. And beyond that, knowledge of the pathophysiology should be what guides your antihypertensive choice. So with that, I'll finish and be happy to take any questions, I guess, after the next speaker. Thank you. Oh, and that's, there's a picture of Newcastle. I'd like to see you all down there one day and return the hospitality that you've all shown me. Thank you.
Next, again, Professor Alistair Hall, back to stage walking. The topic will be management of hypertension. Can we do it better?
See if the slides come. Okay, whilst we're looking for the slides, clinical trials are not everything. They are compass reading. If you are in a jungle and you know where north is and you know roughly you want to go south, you're being helped. But guidelines, they're like a map. It shows where the river is, the bridge. That's good too. Compass, map. But then in the real world, when you get to the bridge on the map, there is no bridge. You're going to have to swim. That's the real world. So a lot of medicine, all of medicine is in the real world, which is more important than the compass or the map. So they are helpful, but they're not everything. And this is a good example. We saw, of course, it's impossible, I would think, to do an adequately powered, controlled trial. And it's true of most individual patient circumstances. So there's always going to be the need for us as doctors. Computers will not be able to run medicine for us. We're going to talk about management of hypertension. Can we do better? This is your Lotus Tower, by the way, which is very beautiful. Black and white. So I have a slide in one of my other presentations with Theodore Roosevelt and the picture that he was sitting for when he had a brain hemorrhage and died. And his physician said, you know, his blood pressure was about 220, 120, but who knows why the artery decided to pop. So that tells us where we were in the 40s. We had no drugs to speak of, no real sense of prevention or stages. You know, it was just, you know, you died from it. Fortunately, hopefully we don't see these sorts of emergencies, urgencies as often. If we do, medicine non-adherence, you know, perhaps is one of the factors upstream. And that's why we should always be thinking about that. If we take a global perspective, this is a chart of cause of death in the year 2030. We haven't got there yet. This is millions, and we have 18 million dying from cardiovascular disease. There's cancer, chronic respiratory, malaria, and so on. But 7 million are directly attributable to hypertension, 7 of the 18 million. So apparently, if there's one thing we could do to change this graph, it would be diagnose and manage hypertension. But only if we do it in a way that affects mortality. Otherwise, to be honest, that graph will stay the same. So I'm going to talk a little bit more about that because we're talking about maybe how to do what we do a little better. We've seen this graph before. We know that green is the life course we want to go on. We never really get hypertensive because we're exercising. We live a long life. We don't have much disease. We're trying to shift people from the red line to the blue, maybe across to the green line. But to do it at this stage of life is very difficult. Really, this is where the problem is. The trajectory we set up in early life is going to influence the rest of our life, and this is ultimately where we're going to have to concentrate. We've talked about aging of the arteries. It starts there. That's supposed to be an endothelium, subendothelial space, intima, a little bit of a fatty plaque. We have an artery that goes out during systole, comes back in diastole, low systolic, high diastolic, or not a wide pressure. This is supporting in diastole the blood pressure. Over here is a hard artery. It doesn't go out in systole, so systole goes up. Diastole is low because there's no recoil. And that's the strongest single predictor across the life course, is the pulse pressure, the difference between diastolic and systolic. So your diastolic going down in old age is not necessarily a good sign. Systolic going up, diastolic going down is a hard artery. And I think blood pressure, to a large extent, is telling us what else is going on with atheroma and other things, the age of your arteries. So we need to look after the entire artery, and blood pressure is part of that. This pure study, which was done in a rural environment, shows that a large proportion of people would be hypertensive but unaware, on no treatment in a small, or maybe on treatment but not controlled, and only a minority are on treatment and controlled. This is not your urban setting in a developed country or whatever, but it's more typical of the world that we're trying to help. Now, my question is, if we're going to use meds even when we're controlling blood pressure that haven't been shown to extend life, okay, we're doing it to prevent morbidity. Stroke is terrible. Kidney failure is bad. So it's still worth doing, but why not do the best? And to do that, we're going to need to look at drugs that can extend life. I've told you I'm enthusiastic about this class of drug. Let me tell you why. This is Barthrops gyrarica. It lives in Brazil. It bites you in the neck and it kills you by dropping your blood pressure and stopping the renin-angiotensin system supporting it. Barthrops gyrarica. Medicinal chemists in the 70s said, what does the snake know about blood pressure lowering that we don't? We'd like to help. So they got the snake venom. They isolated the proline molecule on the end of the snake venom. They changed it a little bit, and captopril was the result. Just going to see if I can make this work. Okay, not. Captopril at the top. It's an adjustment of the proline amino acid. It's got a sulfhydryl group. Sulfhydryl groups for older doctors was phenoxybenzamine and quite a few other things that put protein in your urine and were toxic to the kidneys. It also gives you a bad taste and it gives you rashes. It is a covalent bond, sulfur to sulfur, that doesn't break, an irreversible antagonist. So it was causing side effects with captopril. The dose was dropped, the sulfhydryl group was rehabilitated to a degree, but people changed the design to a carboxyl group. Some went down this path, keeping it water-soluble. Some went that way, which is more fat-soluble. And we're trying to inhibit ACE, which has two active sites, one of which is preferentially for bradykinin. It's sort of curled against the endothelium. It's harder to get to. Bradykinin is local there. One is more in the circulation, and when this breaks off the endothelium, both are, of course, accessible. So we have perindopril at the lipophilic end, captopril down at the hydrophilic end. This is the shortest acting agent, captopril at 6 hours. Perindopril at 24 hours is again quite different due to this profile. Let me tell you about the endothelium. We heard that shear stress wasn't great in dissection, but otherwise shear stress is good for your endothelium. As it gets shear stress, it produces nitric oxide, which relaxes your artery and stops clotting. It's called exercise. That's how we get shear stress. You rub your endothelium and you get a healthy one. It's a big organ. If you put it in a bucket, it's heavier than your liver or your brain or your heart. It's a big organ, 1 cell thick. There it is. And in my medical school, they said it's a non-stick lining. It was one sentence in one lecture. But it's more sophisticated. Beneath it is a space, which is even less exciting in medical lectures. It's called a space, subendothelial space. Then we've got the muscle. They're more exciting. They contract, they relax. But look at this space. This space can accumulate cholesterol, and when it does, it can cause heart attacks and stroke and death. So that space is really important. Not like in medical school where they said it's not that exciting. And the endothelium turns out to be really important too, because it's guarding the space, even though it's only 1 cell thick. So we heard about endothelial dysfunction in the hypertension crisis. You know, one of the mechanisms, of course, is probably the nitric oxide and so on. But let me just show you this experiment. This is just a diagram, obviously. Infusion of angiotensin 1 into a rabbit. It's converted into angiotensin 2, and we're getting cell death, making holes called apoptosis and disruption of the endothelium. The AT2 receptor is vital for the creation of all blood vessels. Blood vessels are made as a hard tube, which then kill the cells in the middle, and you get a blood vessel with a hole, same way as you make fingers. Apoptosis is an intentional cell death, which is used for sculpting blood vessels and other things. Here, making holes in your endothelium would be great if you want to put out inflammatory cells or other things, but the rest of the time it's not so great. And if you feed these rabbits high cholesterol, we can see it stained in the aorta red. Here in the diagram, it's got into the subendothelial space. The presence of this makes plaque formation more likely. Again, in these rabbits, because you can't do it in humans, if you give them an ACE inhibitor, they're not stimulating this pathway. We haven't got apoptosis. You feed them high cholesterol, they don't get plaques. It's very simple. Your endothelium is important. Okay, if you learn nothing else today in this part, endothelium is really important. If you could look after your endothelium, your patient's endothelium throughout life, you'd be doing a great job. One of the reasons it's important is it makes this substance nitric oxide, which is a relaxant substance, naturally relaxing, constantly made, but it's also an antiplatelet, stops thrombus. And the endothelial cell here is stimulated through acetylcholine, shear stress with exercise, but bradykinin through the B2 receptor. Everyone in this room who is healthy has a level of nitric oxide which is hard to measure because it's so volatile, but you have some at the local level. It's what's keeping your arteries relaxed and stopping blood clotting. It may be helped by the exercise, relaxing with acetylcholine, but bradykinin is another mechanism there. So we're going to come to how that may be important, but if we look more generally at the pathology of hypertension, we see hypertrophy of the smooth muscle cell, narrowing of the lumen, which causes pressure waveforms, which are increased in systole, partly as well due to a resistance effect of bounce-back pressure waves. Over here, we have a more compliant, healthy blood vessel goes out during systole, in during diastole. The pressure wave bouncing back is less, so-called central pressure is less. So we can see this is the result of the anatomy of your artery. So as well as hypertension damaging your arteries cause hypertension. We know this is a vicious cycle. In this study, which is ASCOT, we saw it earlier. Remember, they got 4 things reduced. Primary endpoint, death, etc. I showed you with perindopril, amlodipine. There's thiazide, atenolol, and this is the arm blood pressure throughout the trial, and they are identical. Think about that for a moment. If you didn't care about the outcome of the study and you looked at identical pressures, you'd say, well, let's go for the cheaper option. Let's go for the atenolol thiazide. Interestingly, in a sub-study, they also measured central pressure. Those were quite different. Central pressure is a more complex thing to measure, but it's to do with the elasticity of your artery, the waveform being reflected, and so on. But that more strongly predicted the mortality, stroke, heart attack, because this is the pressure, the central one, that the kidney sees, the heart sees, the brain sees. But it's showing you something else, that not all drugs that lower blood pressure equally are having an equal or a similar effect on the biology of the blood vessel. This is also shown as regards to the Europa study. This is the bradykinin level in controls who were considered to be healthy, ones with coronary disease. Before and after treatment with perindopril, it's renormalized but stayed low on placebo. The point here is people tell you ACE is raising bradykinin, that must be bad, cough, etc. It's normalizing it, and bradykinin is absolutely essential to healthy vascular control. It's the B2 that's constantly stimulated. The B1 effects, which are what come into play if you had a more extreme inflammatory situation. So this is renormalizing. And in that trial, perindopril alone in people with coronary disease was reducing major events. I could show you a similar trial for ARB, but the curves would be together. It's slightly hard to do, but probably the closest would be Transcend, no statistical difference. There are many molecules, as we've said. They do differ as regards to lipophilicity. This is actually bradykinin stimulation. So bradykinin is most stimulated with perindopril, least with the water-soluble versions. These are the clinical trials summarized where beneath the line was negative or neutral, above is positive. And if we put in the perindopril trials, there's a striking positivity, which when we look over here at bradykinin, may or may not be associated, but it's certainly something we're going to have to consider. But people say bradykinin is causing cough. This is a meta-analysis of 150,000 patients, all ACE inhibitors. The average cough rate, as you can see, is about 10 to 15%. The one drug that didn't fit that pattern is the one stimulating bradykinin. I think it's because it's sensitizing that mechanism is one of my understandings of that effect. But it's the reverse of what you would predict if the level of bradykinin stimulation we're seeing here is causing cough. Also, there's some evidence that if we combine with other agents, whether it's amlodipine or a diuretic, that the cough rates are reduced. This is the whole concept behind the combination therapy. One tablet is balancing the side effects. So if you have calcium channel blocker with ankle edema, but you have diuretic, you don't have ankle edema. And there's some suggestion the ACE cough also is minimized in that way. This graph is showing the prevalence of coronary artery disease at a premature age. We got it in Africa and Russia, less so over here. But there's another line, and it is showing us the use of ACE, which is less in the east than the west, ARBs, which is more in the east than the west. I've shown you where these drugs were discovered: USA, Japan. Up until recently, there's been 8 companies promoting one class of drugs and next to none promoting the other. And it's down to cough. But if we look at the on-target study, the cough probability is 4 times as much with ACE than ARB. That's true, but it's the same in Asians as it is in non-Asian. No difference whatsoever. So whatever's going on here could be going on there, and vice versa as regards cough. There's other factors clearly at play. We did an analysis in 2006. We showed that ACE inhibitors reduce death, MI, stroke, and we showed in parallel that ARBs were reducing stroke, but not MI, and consequently not death. When we published this in 2006, were considered to be very controversial and provocative. But the data is speaking for itself. This is a meta-analysis. So we say certainly there's something here to think about. And it might explain why death is not reduced. A more recent analysis, this one done in 2015, someone else, looking at total mortality. We have indapamide on its own and calcium channel blocker ACE. I've put in my choices there. Reducing death. These ones, which include beta blockers, reducing death but not significantly. And then ARB down here, not only not reducing death, okay, forget the significance. It's non-significantly having no effect. Why then are we selecting that class of drugs? And I ask that as a really honest, open question to anyone who wants to answer that to me. I think I know some of the answers. We believe that it's better tolerated. Use placebo. So there are many combinations: perindopril, amlodipine, valsartan, amlodipine, olmesartan, amlodipine. But do they all have survival data? This is my challenge to you. If you're given the option of these, ask to see the survival and or other hard endpoint data. I've shown you some data about perindopril as regards to atheroma and as regards to elasticity, central pressures, and I've shown you data on MI, stroke and death, predominantly with combinations, perindopril and other things. All of that is important to me, and yes, sometimes we have trials, sometimes we don't. I had to show you some rabbit data. I've shown you a sub-study of another study called CAFE about the central pressure, but we know what happens up here. So the rest, yeah, we're trying to figure it out. But notice I didn't put lowering blood pressure as one of those factors. Not because it isn't important, but because it's shared by other drugs. And I think if that's all you can do, it is important. If you can do more, that's even better. So this is my personal practice. I'm selecting from those three, and usually perindopril first, based on the evidence I showed you in the last presentation in here. I'm often going to combination. I tell patients even now, you're probably going to be on 2 or 3 drugs. Would you like to start straight from the word go on 2 drugs? And, you know, they all do. Mostly because I probably tell them I think it's a better plan. I say we're going to use lower doses, we're going to get synergy, etc. You may end up on 3 drugs. We'll get there quicker if we have to. And we use lower drugs of the 2, it's true. We're not going to top doses. But when we look at the American guidance, which will come elsewhere too, 120, you know, there's 2 ways we can get there. We're going to either have to use more drugs at stronger doses, or we're going to have to start treating earlier. And the idea here is to treat more effectively earlier with the combination therapy. This is the summary of what's happened with guidelines over the last 10 years. First of all, they said increase the dose of 1 drug. Then they said if 1 drug doesn't work, change it to another drug. Then they said start with 1 drug, then go to 2 drugs. In the future, we're going to start with 2 drugs based on the European advice. And here is the advice in the press release. Drug therapy extends to additional groups of patients. The targets come down, and that using a combination therapy early in the practice is being recommended. So typically, hypertension is asymptomatic. That's its problem. People don't feel better on our drugs. We're treating it because we want to prevent morbidity, but also mortality. We're not treating the pressure per se alone. Lifestyle changes are critically important, and when my patients say, I don't want to take your drugs, I say, brilliant. Go to the gym. Come back in 3 months after you've lost weight, gone to the gym, stop smoking. We'll talk about the drugs then. Okay, they come back in 3 months, they say, tell me about the drugs. So, but at least they're on board. You know, they've tried. And, you know, maybe they'll change a few habits. So choice of drug therapy is often driven by other diseases, and certainly I've illustrated that with the beta blockers. Essential hypertension is without identifiable secondary causes, but, you know, that doesn't mean there aren't secondary causes or contributing causes, such as alcohol, such as weight, such as sleep apnea. So we need to keep an open mind. And then the main goal is to reduce mortality, but also the morbidity. So I'm ready to stop. I think we're taking questions, but I want to summarize my key points. The new guideline says start earlier at a lower pressure. Treat almost immediately with a combination, because then you get control early, you don't lose the patient through all these titrations, and you get more efficacy and adherence. And then aim for a lower target. Remember, it's going to be aim. We're going to have the same discussion with elderly patients, what's achievable. That still gives quite a lot of leeway for us to choose which agents we're going to do that with. And the guidelines are very non-specific on the selection process. That's down to you, and you're looking at the trials. You may have other preferences, but I just encourage you to think how you're making that decision and factor in some of the elements that I've suggested, which is mortality, hard endpoints like MI and stroke. Thank you.
I think I will call Professor Andrew. We have got 15 minutes more. We can take some questions. Professor Alistair Hall,
hello.
What is your take on renal denervation therapy? Yeah, after the Simplicity 3, now the new...
Sure. So renal denervation, of course, looked very exciting, and then it looked less exciting, and maybe it's going to come back in selected patients. So for those not familiar, it is doing an ablation, which is an electrical impulse to the renal arteries at different places to get rid of sympathetic nerves and lower pressure that way. So it's a clean treatment in the sense of you're not taking lots of drugs, and it's usually used in resistant cases, so we'll hear other views on this. When we tried it in Leeds, we had to prove that they were resistant on drugs. And the way we did that is they came to our clinic, they swallowed the drugs in front of us, and then they went out with a 24-hour blood pressure machine on, but usually they didn't get out the door because they fainted because the drugs were too strong, meaning they hadn't been taking them for whatever else had been going on. So witness drug taking seemed to change the situation. We're going to hear more maybe, but the trial that was randomized, failed to show a benefit, and it's now being developed for maybe selected cases in different ways. So not quite as promising as we first hoped.
The latest one presented in the PCR, published in Lancet last month, I think the spiral hypertension trial is again showing benefit with renal denervation. You are talking about the Simplicity 3.
Sorry, maybe you'd like to comment as well.
Yeah, I think you're talking about Simplicity 3,
yeah.
which failed against a sham procedure control. And there were some technical issues, I think, with the trial and the inclusion of sites there. The more recent data with more effective ablation catheters have been much more compelling and, in fact, have shown benefit over sham procedure controls. So I think the field's coming back to life somewhat.
There's more selection of the patient, I think, now as well.
Well, yeah, there is, and the recognition that people should be on a mineralocorticoid receptor antagonist, because that's one of the causes of resistant hypertension is aldosteronism, and it's under-recognised. And so I think with all those caveats, I think there's still life in the fields. But what you're talking about is treating patients younger, more aggressively for longer, and adherence is a real problem. And I think patients are intuitively drawn to a one-stop shop, one-off therapy, and a lot of people really ask for it, in my experience.
Renal denervation, to my understanding, it was the sustenance of the benefit that was not shown in the Simplicity 3 and the latest trials. But because spironolactone produces sustained blood pressure reduction more than 6 months, whereas the renal denervation didn't show that. My question to Professor Alistair Hall, you were telling about the SPRINT trial. So has SPRINT trial had any effect on the European or the NICE guidelines?
So I'm sure it's had an impact on the European guidelines, which I know from verbal presentation in Barcelona last week. Haven't seen a published version. NICE is continually reviewing, but online, not the ones that people know, and clearly they're going to need a refresh as well. I would be surprised if our targets didn't come down. Maybe like the Europeans, it'll only come down halfway to 130.
But do you think that SPRINT trial is very practical and whether it is a correct trial to interpret in the way we are interpreting it, because the trial blood pressure monitoring was done very automated way, where even the observer was not there, and it was totally automated. The patient was only there in the examination room and the blood pressure was automatically connected. And studies have shown that if you have a blood pressure measurement of that sort, it will differ at least 20 millimeters systole and 10 millimeter diastole from the sphygmomanometer or the Android type of measurement. So it automatically says that whatever we measure with the mercury blood pressure meter, 140/90 still stays. So what is your opinion?
First of all, it achieved total mortality, which is impressive to me as a cardiologist. Total mortality was reduced. So I always look to that first in every trial. We're using ARBs with no total mortality, no primary endpoint. So when we're picking points of design on a study like SPRINT and saying maybe we shouldn't believe it, I think we're not doing a service to our patients, my first point, even though the point is valid. It's a different way of measuring pressure. There may be slight bias kicking in. For me, I'm looking outside of the trial at the life course of hypertension, what I personally would like to do. So I don't have hypertension, but I would take these drugs because I'd like to keep my arteries younger longer, and I don't want to develop it later in life. So if that's my thinking, then I'm willing to accept a direction of travel, knowing it'll be very difficult to be pure about achieving those targets. But I don't feel that obligation. I think it's just a direction of travel. I think now when I see 145, 50, I'm less likely to say, okay, it's probably just a one-off reading. Maybe I'll titrate at that level. Whether I'll keep going to push it to 120 is less certain.
tend to be using ARBs far more than AC inhibitors. Do you feel that we should get back to AC inhibitors? I think possibly due to side effects and availability of telmisartan and so on. My view is that far more ARBs are used than AC inhibitors. And also what the reason is that mortality reduction is more with AC. Is it the bradykinin that causes the difference?
So my view, I think, was clear.
Yeah.
I think the evidence is with ACE and not with ARB. I understand that you and others think it's safer to use an ARB, better tolerated. I'm saying same with placebo. So I think it's a marketing issue over the last years that's partly made people's attitude that way, see the data differently. But my view from the patient is that we're asking them to go into a long future of treatment, blind, other than the studies. So I think we have to somehow tell them, if you follow this sort of study, then this is what you might expect in the future. Otherwise, in a sense, we're making up a plan. And it may be valuable, as you say, just to lower the pressure, but I think it's important also to prevent MI, certainly in my setting where it's twice as likely as stroke. In your setting, maybe stroke is more of an issue, and I would respect any judgment you make, but I'd like to offer you this data to maybe challenge some of your thinking also.
So it's worth considering changing back to AC inhibitors, is it?
So if people are going to switch from ACE to ARB because of cough, then they should switch from ARB to ACE because of MI. If you have a patient who comes in with an MI on ARB, switch him, her, would be my advice.
Some more time left if you have any questions. Professor Alistair Hall, now your lifestyle modification, you mentioned exercise and even the moderate alcohol consumption. Do you think that the moderate alcohol consumption will reduce the blood pressure?
Didn't quite hear the end of that, but I know the first part. Lifestyle is critical to our well-being, to old age, if we want to get old and be healthy. In hypertension, you know, people with regular exercise, cutting their alcohol, which is quite large where I come from, can see fairly marked changes. Salt restriction is more important maybe in a country where it's not regulated. In my country, it's quite carefully regulated, but other countries, it's free salt intake. So I think there are these factors which are absolutely important throughout a life course and after we diagnose hypertension. I'm not really aware that more aggressive engagement in lifestyle is competed against drugs as patients want it to, but you know, if a patient is not taking drugs, they certainly need to be advised on.
So what about the moderate alcohol consumption? You have mentioned alcohol consumption,
Yes.
moderate. Does it help with the blood pressure control?
So alcohol is not metabolized fully. It makes a byproduct which elevates your pressure and is dangerous to your endothelium. So if you drink large amounts of alcohol, overcome the way of metabolizing it, you get these side products, and they're also cancerogenic. So I think alcohol is about a dose effect as much as anything. Smaller amounts have been suggested to be vasodilatory, may be beneficial in other ways. Large amounts are the ones that would be associated.
So the moderate alcohol consumption may be beneficial.
I didn't quite get that, but
This is the point in discussion now.
they laughed. Well, my alcohol consumption is very small. Yes. Do you want to just shout, maybe?
Yeah, I was just going to clarify the point on the renal denervation, because actually I'm one of the Radiance investigators from the UK. So we know that renal denervation with the old studies and the old catheters didn't work. That's pretty clear, and there was issues with patient compliance. So the two new trials using two new catheters, the one that I was using was the ultrasound catheter, were investigating in patients that were off meds, and they had urinalysis and chromatography. So these were patients that had systolics less than 170, because for obviously ethical reasons, but greater than 140, as well as diastolic hypertension. And the interesting thing about this study, in fact the hardest bit about this study, was that patients had sham procedures. So we did the procedures in the cath lab. We worked with our hypertension team in a multidisciplinary team and our interventional radiologist. And at the point the catheter went in the vessel, everybody was sent out of the room apart from myself. The patient was randomized to active treatment or not, and the patients didn't know. And I think it was very crucial. And so the results showed that we're getting about an 8 millimeter on the 24-hour ambulatory, which translates to about a 15 to 20 office blood pressure.
So that's in the sham group?
No, that's compared to sham. Sham was...
Over and above the sham. What was the sham effect?
Minimal. And in fact, we found that some patients in the sham arm on urinalysis actually had some drugs. It was interesting that some of these patients were concerned, although they didn't know. And they were recently unblinded, and I had a couple of patients that one, when I rang him, said actually you didn't have the procedure. I was completely surprised. And as part of the study, there was a second team who were monitoring the patients, according to certain blood pressure. But just to finish, my personal view is that actually this technology, okay, we're focusing on blood pressure, but actually I think it has a major role in things like heart failure, particularly HFpEF. And I'm doing a trial with Imperial where we're doing similar sham procedure in patients with systolic heart failure. And so actually, I'm glad that, your point about the technology coming back is really relevant, and I think it will have a space in some niche patients.
Yeah, agreed. In conjunction with AF ablation, with heart failure, there's a whole new world of opportunities waiting for this technology, I would hope.
Pleased to hear it.
Thank you very much, and I would like you to accept a token of appreciation.
That's great. Thank you so much.
Thank you, sir, and thank you, chairpersons. With that, we conclude the last symposium for the day, and we are about to take a refreshment break for a short while. And during the break, we would like to invite you all to get hands-on experience on TAVI. There's a simulator station at the trade stall near the Prince Philip room. Please be back by 5 p.m. for us because we have planned an exciting, clinically interesting lecture following the tea break. Thank you.